People will type in or okay, thanks. Okay, I appreciate that. Thanks.
Hey everybody, welcome to our second class in our 3-month process of Advanced EMT. A couple of housekeeping things. Scott will not be able to be here today. Scott's on duty at Ethnicity. Just a reminder that all of these now are going to be put on YouTube, so look for links that Scott is sending where you can find them. Also a reminder that the review, good morning Scott, the review quizzes are put on at noon. Scott locks those down to 20 questions that you can take 3 times. So they're put on at noon after the class is given. We haven't seen the questions, so Janely's flying a little blind on that, but don't worry about it. You get 3 opportunities to take that quiz. Apparently there was some problems with the first day on the quiz. It only allowed you to take it 1 time. He's corrected that. Okay, well, here we go. We're going to spend 3 hours this morning on Chapter 8, Pathophysiology. The Chapter 9 is really just a review of the body growth. I'm asking you to get in the book and review that and take the review quizzes. It is absolutely 100% review stuff. We really felt it important to spend the 3 hours this morning getting into the perhaps most difficult part of the AEMT curriculum, and that is the pathophysiology. So thankfully, we have an expert in the room.
Hardly.
Not allow me to say that. This is my wife. I'm so privileged to introduce Janely. She's a professor of physiology at Gonzaga University, and it starts back Monday, or I guess every day this week except today. But get to know her. She's great. She's an incredible teacher. Thank you for doing this.
You betcha. Thanks. Thank you. Thanks for having me. You realize he's very biased, right? But I appreciate it. So thanks for inviting me, Steve. I know that one of the reasons he invited me is because this is one of my favorite things to talk about is physiology and pathophysiology and how it applies to what we do when we're caring for patients. So welcome to my world. I love this stuff. I know that we have a lot of content to cover, and what I've done is I reviewed the objectives. I pretty much looked at, first of all, when Steve shared with me the objectives, I said, and how many days do I have to cover this? And he said, well, you have 3 hours. And I'm like, that's crazy. So I'm going to share with you how I've organized this information. Hopefully it will be in a logical flow so that it makes sense and we build on the content and build on what you already know. I will identify those areas that we're not going to be covering that you'll be needing to look at on your own, to review on your own. If you have any questions, I encourage you to please say so. We've got a nice small group here, and I know there are some folks online watching as well. Please feel free to ask questions as we're walking our way through, because I want this to be an interactive experience, because it's hard to sit and listen to somebody talk for 3 hours. So let's just kind of have a conversation about this stuff. Sound good? Okay, that's my plan. All righty then. Well, with that, let us go ahead and get started. This is Chapter 8 in your Mongo book, Pathophysiology. And this is to do with the National EMS Education Standard Competency of Pathophysiology, which reads, integrates comprehensive knowledge of pathophysiology of major human body systems. And of course, the knowledge is really good to have, but it only is helpful if it's applicable to what we do when we serve our patients. And so I'm going to do my very best to take the concepts that we talk about and apply it to patient care so it makes sense. That's my goal. Okay, stand by. It worked a moment ago, I promise. Oh, okay. Oh, you're so good. Thank you, Pete. Appreciate it. All right. He is. IT guru. Okay, so the definition, of course, of pathophysiology is the study of ology means the study of, the physiology of altered functioning in the presence of disease. And thankfully, through research and through clinical experience, we've gained a lot of knowledge about the way the body works, but then what happens when there are alterations in the normal physiology. The good news is we have a lot left to learn. And so I kind of look at the human body as like a playground to explore for the rest of my life, to learn how it works and how there are alterations, how we might impact that. So I'll share with you to my level of what I understand and how I think it'll impact, but please recognize that we're continually learning. And there may be things you do in 10 years that you're going to look back and say, well, that's not consistent with what we were taught 10 years ago. That's okay. That's just a demonstration of the progress as we learn more and more about how our human body works. Okay, the factors that contribute and lead to disease, there are many that are controllable and many that are uncontrollable. First, I've listed a few of the uncontrollable ones. We are all mortal. So age-related factors are going to contribute to the disintegration of how our bodies work. Genetics, in just, maybe a decade ago, the Human Genome Project was completed. So we now have a map of all of the genes that make up the human body. And we thought, gosh, once we get the human genome figured out, eureka, we'll know it all. But all we did was we got a map. Now we need to learn, okay, what does this address mean and how does it impact the other addresses around it? So it's just the tip of the iceberg. But we're beginning to identify genes that when there's a mutation identified in a particular gene, we can anticipate that it will lead to a particular pathophysiologic alteration. And so that's going to be more and more important as we walk through the next decade or so. It'll impact the way we care for patients. Welcome. Race, ethnicity. I think we've all learned that certain races are at higher risk for particular disorders. For example, cardiovascular disorders, hypertension. We know that those of African descent or those of Pacific Islanders have higher risk of hypertension just because of their race, and that is a genetic impact as well. We need to be aware of that as we care for patients, because when I'm caring for somebody who is a Pacific Islander, I'm going to know that they're at greater risk for hypertension and greater risk for type 2 diabetes just based on their race. Nothing in their control, but they already kind of have the deck stacked against them, if you will. And then environmental factors. Many times when we take histories, of our patients, we'll find out what is the job that you do. Well, if we find out that they have worked with pesticides for the last 25 years, we might anticipate that there's going to be some chemical injury to their cells. If we find out that they have worked unprotected in an environment where they've inhaled toxins, they might have some respiratory complications that others wouldn't have. But that's part of the impact of their physiology. Now, those are uncontrollable for the most part, although we're learning more about it. Controllable factors are things that people make decisions about. And we're learning more and more about what goes into making the right decisions. But as we all know, just because we know what's right doesn't mean that we do what's right. Can I hear an amen? Hello? Yeah, especially coming off the holidays. Holy cow. So we know that it's better to have something healthy rather than some cheesecake after. But what are we going to have? I know. My husband doesn't agree. But we want to take into account the nutritional factors that impact a person's physiology. Activity level. It has been said that a sedentary lifestyle is the new smoking. Have you heard that? That if a person has a sedentary lifestyle, it impacts their health as negatively as smoking used to. What we now know about smoking, isn't that something? So activity is really important to teach our patients. Lifestyle choices such as smoking, drinking. You'll notice I put diabetes and hypertension as controllable factors. Why do you think I did that? Say again?
Tied into nutrition.
How is it tied into nutrition? Good.
Kind of consequences of, sometimes it's uncontrollable, but a lot of times it's consequences of your nutritional choices.
Absolutely. That's so important. And the more we learn about, for example, blood sugar control, I assume that's on your mind when you're thinking of nutrition. We know that it's important to keep our blood glucose within a certain level, and we know how to do that. but patients don't always choose to do that. That's why it's a controllable factor, because we have demonstrated through research that people who have a blood glucose, even if they have type 2 diabetes, if they have blood glucose within normal range, they have pretty much the same lifespan projected as somebody who doesn't have diabetes. And so same with hypertension. If a patient has controlled blood pressure, their risk of complications from hypertension is way lower than those who have hypertension but don't choose to control it. So that's why we have that listed under the controllables. Any questions about those? Makes pretty good sense there. Okie doke. Oh, wrong way. So these factors and others can lead to a number of problems, which leads to the pathophysiology that we're going to be focusing on this morning. The first are alterations in cellular function. Pardon me. The next is inflammation and immune response, which kind of leads from the cellular dysfunction. And then as we get a little bit bigger, we're going to talk about the imbalances in fluids, electrolytes, and acid-base balance. And then we're going to talk about the consequences of hypoxia or hyperperfusion to the tissues, what we have known as shock, because I know that you all will be encountering that when you answer calls, and you want to be able to distinguish what has caused this and how might we best treat this. And then alterations in body system functions. There's a whole section in Chapter 8 called, what is it called? Familial diseases, and it goes like by system. I encourage you to look at those by yourself because we won't have time this morning to cover those. But I just give you an open invitation. If you ever have questions about that stuff, Steve's got my email address. You're welcome to shoot me an email question and we can talk about it via email. But I do encourage you to dive into that information on your own. So this is sort of a roadmap for our time together this morning. Make sense? All right, we're going to start with alterations in cellular function. Darn, I did it twice. Cells undergo adaptation when exposed to adverse conditions. First, I want to make sure that we're all real clear on some terminology that is used throughout your chapter. Atrophy. Who can give me a good definition of atrophy? What does that mean? Say again? Good, goes away, diminishes, decrease in size. That's exactly right. So when we're talking about cellular alterations, it's actually a decrease in the size of the cell. When we talk about it in the tissue, like muscle atrophy, it's a decrease in the size of the muscle tissue. So a decrease in the size. Then conversely, what would hypertrophy be? What do you suppose? Increase in the size, exactly. And this is different from hyperplasia. Hypertrophy is actually an increase in the size of the cell, whereas hyperplasia is an increase in the number of the cells. Both are going to lead to an increased, what we see with gross anatomy, an increase in the size of the tissue, but it's a different pathology, whether it's an increase in the size of the cells or an increase in the number of the cells. Make sense? Okie doke. And then the other two terms here that I want to make sure we're real clear on is dysplasia and metaplasia. When you hear the term dysplasia, what comes to your mind? Dysplasia. What, say? Okay, something's wrong. Good, something's wrong. Dysfunction, disequilibrium. Dys is something bad, right? And so dysplasia is an irregularity or something has gone awry with the size of the cell or the shape of the cells. A dysplasia, when we look at cells in a microscope, we know that a normal skin cell is supposed to look a certain way. If I have taken a sample, a biopsy from my skin, and I see a cell that doesn't look like a skin cell, but that's where I got it, that's a dysplastic cell. That's dangerous because that's cancerous. That's a characteristic of cancer cells, is dysplasia. They kind of don't play by the rules. Cancer cells don't. And so when you see dysplasia on a slide, it really raises a red flag for you as a practitioner, as a provider. Now, metaplasia, that's a little bit different. Rather than a change in the shape and the size, it's almost like a mature cell has been replaced with another mature cell type for some reason. And so this is actually reversible. Metaplasia is reversible, whereas dysplasia is irreversible. And so on the continuum of which is worse, dysplasia is worse than metaplasia. Make sense? We take all of these terms into account when we're evaluating on a slide a particular shape of a cell, because it's going to give us a prognosis as to what's going on with the patient health-wise. And so we pay attention to that. Any questions on those terms? All right.
Hey, Jelly?
Yeah.
For the class, Scott will send out, Scott Teacher will send out Janely's email address, so you all will have it in an email from Scott. If you have questions, she's very willing to answer emails.
You betcha.
And
I love to talk about
you
this stuff,
something
even
to
on
the guys
email.
The microphone that are watching online.
Yes.
That they can either plug in a chat question,
Okay.
and I can read it to you.
Steve has just reminded me, for those of you who are watching online, where's my camera? Hello. For those of you who are watching online, if you want to have a question yourself, please feel free. You're a part of this discussion. Just type in your question, and either Steve or Pete will share that with me so that I can address it for the whole class. So come join us. Okay. A couple of other terms that I want to make sure everybody is clear on, and that would be apoptosis. Apoptosis is kind of a funny word, but it is a normal programmed cell death. I'm sure you are aware we are mortal beings, and so the cells that we have a life expectancy. Most cells are going to at least post. Once we've come together as a human, our cells will divide and replicate through mitosis. Remember that from biology, right? There are only so many times that a cell will divide, though. Anywhere from 50 to 70 times in a normal human body. Different types of cells have different numbers that they'll actually divide. And with each division, there will be a part of the chromosome that's going to deteriorate. It's called the telomere. It's at the end of the chromosome. And with each division, that gets a little shorter and a little shorter. So essentially, as you think of a photocopier, when you make your first copy, it looks pretty much like the original. But then if you make another copy from that copy, it's a little less like the original. And the same as you get farther and farther into the copying. Are you with me? Same kind of thing as our cells divide. With each division, they lose a little bit of their genetic material, to the point where they enter into an stage called senescence, and that's programmed cell death. In other words, the sun is setting on their life in my body. And so they will die a very beautiful death, where they kind of close in on themselves, and they dissolve, and what is left over is actually going to feed the cells around them. So it's kind of a beautiful thing, apoptosis. It happens all the time in our body, and we are put together that way quite on purpose. Now, so this kind of gives you an example of it. This diagram will talk you through it as well, but it's part of normal development. Proteins and DNA undergo controlled degradation. And it's important that our cells are able to do this because they feed other cells around them. It's just part of the process of the cycle. Now, what happens in some occasions when our cells are assaulted, either by physical trauma or chemical trauma or hypoxia, they enter into something called necrosis. This is not normal programmed cell death, where in apoptosis we have a beautiful, quiet, kind of nice violin music going on, and the sun is setting, and everything is beautiful. With necrosis, it's like the cell is fighting it all the way, and at the very end, it's like it explodes. It's like, I will have the last word, and it explodes on its neighbors, and it causes all kinds of chaos as it dies. So you see the difference between this beautiful programmed cell death of apoptosis and this very traumatic, very dangerous necrosis, which happens in our bodies as well, but it's not normal. It's a pathophysiologic condition. Are there any questions about the difference between apoptosis and necrosis? I want you to keep that in mind because, pardon me, when we talk about different alterations, many times it's going to lead to cellular necrosis, which leads to then the pathophysiologic changes that we see with the naked eye because the cells themselves have impacted the tissue. So it's important that we kind of have that as a background. Okay, this is a great slide that was included on the PowerPoint that just shows the difference between normal tissue and then when you have cells that have died by necrosis, you see this debris that is left behind. It's like there's litter in the tissue that shouldn't be there. If the cells had gone by normal apoptosis, what's left behind would have fed the cells around them and it would have been nice and pink like this. But with necrosis, it causes scarring and problems on the cellular level. The causes of cellular injury include, your text talks about 3 in particular, and so I included those in this slide. The first is hypoxic, which is a common cause, obviously, of cellular injury. What do you suppose would be some situations that would lead to hypoxic cell injury? What have you guys seen? Anything come to mind?
Cardiac arrest.
Brilliant. Drowning, cardiac arrest, anything that stops the movement of oxygen into the cells, beautiful. So anything that decreases the perfusion, decreases the oxygen that's available to the cells, that leads to hypoxia. And our cells are not, for the most part, designed to function without oxygen. Why is oxygen so important, by the by, for cellular function? Why is it such a big deal? All the cells need it, you betcha. It is an absolutely essential component for energy production. So without aerobic or oxygen supplied development of energy, the cell is forced to go into anaerobic metabolism, which is nowhere near as efficient, and it leads to some toxins that our body does not do well with. So with aerobic metabolism, it's the use of oxygen to create energy so that the cell can do what the cell's supposed to do. Very, very important. But incidences like cardiac arrest or drowning will lead to situations where the cells do not have adequate oxygen. And we're going to continue that discussion a little bit later. Another type of cellular injury would be chemicals. For example, it's easy for us all to imagine if I were splashed with hydrochloric acid, do you think there'd be a little injury on little damage to the cells on my arm? You betcha. That's a classic example. Ingestion of anything that's toxic, carbon monoxide, too much lead ingestion, all those things can cause, on a cellular level, cellular damage. And then the last category that your text deals with is infectious. This is an especially interesting type of injury, and we're going to get to this a little bit later. But as you know, we are surrounded by microbes, right? Flora. Many of them are okay. I mean, our body deals with them great. Many of them, however, when they get into particular parts of our body, they cause all kinds of mischief. And they can either release some exotoxin, which is going to cause damage nearby, or if they get engulfed by one of our white blood cells, they can like spit out an endotoxin that leads to a fever or the muscle aches and pains that we have. So they're quite mischievous little critters, and that can lead to damage at the cellular level. So these are the 3 categories that were listed in your book. Any questions about those 3? Make sense? Okay. This is a great picture that was included. It just talks about one of the types of bacteria, in this case, that will release an endotoxin that causes damage to the cells around it even as it's being engulfed by a phagocyte. And this particular slide then leads us into the next section, which is part of the body's defense when it feels like it's in danger. When our body is we are put together in such a magnificent way that we have automatic defense mechanisms in our body. One automatic defense mechanism we have is the fight or flight response. Everybody remembers that. The sympathetic nervous system. If the fire alarm would go off all of a sudden, my heart rate would probably go a lot higher than yours, but heart rate would go up and all these changes would happen automatically in my body. And that's because it's designed to protect me so that I can either run away or fight whatever is threatening me, right? Well, the same thing is happening at the cellular level. So we're going to talk about that a little bit with regard to inflammation and immune response. The body's self-defenses come in many different layers. There are anatomic barriers that decrease the chances of the foreign substances to invade the body. What are some anatomic barriers that come to your mind? You betcha, the skin. Skin is the first one. So if you come upon a patient who has had a laceration, you see that already their first primary defense mechanism has been breached, right? Or even if you start an IV, you have breached their first line of defense. So skin is very, very important. Can you think of anything else that might be a physical structure that protects our bodies? Think of the central nervous system. That's such an important, precious part of our body. What else is involved? In addition to the skin, what else do we have? Bones, yeah, the skull and the vertebrae. Beautiful. We also have those meninges that protect the dura mater, the arachnoid mater, and the pia mater that protect the central nervous system, whether it's in the brain or the spinal column. We're magnificent creations, how we've got these physical barriers in place. Another physical barrier, in addition to something solid like that, would be chemical barriers. Can you think of anything that's built into our body that protects us from either ingesting or acquiring something that could be injurious to us? White blood cells, very good. We're going to get to that in just a second. Hang on to that, because that's once the microbe has made it into the bloodstream. Look out. So stay tuned to that. Think about the toddler who picks up everything they can get their hands on and puts it in their mouth. Why don't they die? What keeps them from dying from the things they put in their mouth? Okay, the gag reflex, very good. The reflexes are very important because it coughs up so it doesn't get into their lungs. Very good. What else? Say again? Okay, if there's something that's noxious, there should be a sense that gives us, okay, that's not something I want to put in my mouth. Toddlers don't always listen to that, but most of us do. That's a true statement. Say again? Saliva. You betcha, saliva. Saliva actually has substances in it that will degrade things that could be toxic to us or that could be dangerous to us. Not only saliva, but also our sweat, our tears, any body fluids. Magnificent design. In addition, if I were to swallow something, what is the pH of my stomach? Very acidic. Now, there's a number of reasons why our stomach pH is acidic. Part of it is for digestion, of course, but part of it is to protect our bodies from that toddler puts in their mouth. It's going to destroy some of those things before it can be absorbed. Isn't that cool? Love that. So that's all the first line of defense for our bodies. And then we get into the immune system, and Justin mentioned the white blood cells. We're going to talk a lot more about that because that's more of a second or third line of defense. Let's look at I've got a diagram here that talks about the difference between innate and adaptive immunity. Your book refers to adaptive immunity in two different ways. It calls it adaptive immunity and also acquired immunity. Most literature will use those interchangeably. I'll try to stick with adaptive immunity as compared to innate immunity. But this particular slide helps us appreciate that there are first line of defense, which are the physical barriers, such as the skin, mucous membranes, the secretions that we talked about. And then also part of the innate immunity are some initial responses that our body are going to employ regardless of the type of invader that's coming in. Things such as phagocytic cells like neutrophils, antimicrobial proteins, we're going to talk about those, the inflammatory response, big part of innate immunity. Who knew? And then natural killer cells, which are one of those white blood cells that come to the rescue every time something arrives in our body that doesn't belong to our body. And then if the invader is able to get past those, then we have an adaptive response that is employed, and that is involving even more of the white blood cells, which we're going to talk about. So there's several different lines of defense that we're going to be talking about here. The first line of defense we've already discussed are those physical barriers. The second line of defense is inflammation. Now, when you think of inflammation, what comes to your mind as a clinician? How do you know if somebody is experiencing inflammation? Redness, you betcha. What else do you see as a local sign of inflammation? Swelling. What else? Heat, you betcha. Maybe some pain, maybe some loss of function if I have inflamed little finger kind of thing. Right. Those are all local signs of infection. And we're going to talk about what causes those. Some systemic signs of infection, if I have, God forbid, I have pyelonephritis, and that's a systemic infection, how might that be manifested in my body? How might I know that? When you take my vital signs, what might you see if I have an infection that has a systemic inflammation? Increased blood pressure. What'd you say? Oh, is that what you said too? Increased blood pressure. Okay. What?
Temperature.
Yeah.
Increased heart rate.
Increase. All of my vital signs are going to be elevated because it is an invader, and the sympathetic nervous system is going to employ, but also my immune system is going to react and raise my body temperature to make it not such a nice environment for that invader. I'm also going to see an increase in those white blood cells because they're going to be recruited to fight the systemic infection. Those are all second line defense. Let's see here if I've forgotten anything I talked about here. Innate immunity, remember the first line and the second line of defense? Innate immunity happens right away. So the minute I inhale let's say I inhale something I'm allergic to, pollen, for example. Every time I inhale pollen, I'm going to have an inflammatory response because my body is going to react because it doesn't belong there. And every time I respond, it's going to be the same response. That's different from adaptive. So keep in mind, innate response is immediate, and it is the same every time I'm assaulted, okay? It happens right away as nonspecific. It includes components such as platelets, clotting cascade, the complement system, all of the granulocytes, a couple of the agranulocytes. I don't know how long it's been since you guys have reviewed the immune system. Has it been, is that pretty front in your mind? I'm getting yeses and nos. Okay, you know what? Okay, no worries. I mean, it's not like normal table talk, right? But I think it's important for us to understand our body's defenses if we have a really clear picture of the immune system. So I'm a whiteboard fanatic, so I'm a little at a loss without a whiteboard, I've just got to confess. So I'm going to use this guy. I've started just to review a little bit about the immune system, just a general overview so that we can all in our minds keep in context, which is an example of innate immunity, which is an example of adaptive immunity. You with me? Okay, so when I think of the immune system, I think of the blood, of course, but I think of it as either cellular components or plasma, components that are existing in the plasma. Now, with regard to the cellular components, you said it, what is the MVP of the immune system? White blood cells, you bet your boots. So white blood cells are the main defender on the cellular side of things for anything that's invading our body. Would you agree? We know that the white blood cells are categorized either granulocytes or agranulocytes. Do you know what determines whether they're a granulocyte or an agranulocyte? Have you ever thought about that? If you were to look at a white blood cell under a microscope, and you'd see the nucleus, and then you'd see the cytoplasm. If the cytoplasm looks like it's got pepper on it, or it's got granules in it, it's a granulocyte. If you look at a white blood cell and it's got a nucleus, but there's nothing in the cytoplasm, it's an agranulocyte. Simple as that. It's simply a phenotypic observation. However, they do have something to do with the function. So with regard to the granulocytes, there are three types of granulocytes. Do you remember what they are? They all end in "phil." That helps. Say again. Say neutrophils. Good, good. Neutrophils.
I pointed it out first.
You're so good. Okay, as long as you found it on the slide, what else? What are the other two? Basophils. 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 And who wants to take a stab at the last one? It's a common word that you use in everyday work. No. Eosinophils is how you say that. Eosinophils. Eosinophils. I worked with an RN that was coming back into practice, and we were reviewing this, and she said, Uncle Ben. That's how she remembers the granulocytes, because she has an Uncle Ben, and he's kind of a protector for her. So we remember basophils, eosinophils, and neutrophils. To this day, I teach my nursing students to remember granulocytes by thinking of Uncle Ben protecting them. So we have basophils, eosinophils, and neutrophils. All of them, if we were to look at them under a microscope, we'd see the nucleus, and then we'd see the granules in the cytoplasm. That's why they're called granulocytes. Now, just for no extra charge, let's talk about a basophil that is still a granulocyte, but it has migrated to the suburbs, and it now lives in the tissues. It is called a mast cell. Very similar functionally to a basophil, but it's got a different name because it's located in the tissues. It happens to line our respiratory tract, mast cells do. Very important in the inflammatory response. So I bring that into the discussion because we'll be talking about that a little bit later. So these are all the granulocytes. Now the agranulocytes, who would like to give me an example of an agranulocyte? Also on the slide, I think. This is the biggest white blood cell that's floating around in our bloodstream. Say again? Monocyte. That's exactly right. A monocyte. 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 Picture a big white exercise ball that's like the size of this room, and it has one nucleus, nothing in its cytoplasm. And it's just floating through our bloodstream looking for anything that doesn't belong to us. And when it sees it, it engulfs it. And so for that reason, it's called a phagocyte, because that means to engulf a cell. Phagocyte, monocyte. Now, if a monocyte decides to move to the suburbs, and it lives, for example, in the alveolar tissue, it has the same function, but it's not called a monocyte. Do you have any idea what it's called? It's on there. Macrophage. Sorry, I didn't realize those were on there. So a macrophage is essentially a monocyte that has moved to the tissues, both of which are going to engulf some pathogen that doesn't belong to the body. And these are also part of the white blood cells, part of the immune system. These are also part of the innate response. We'll get to that in just a moment. In addition to the monocytes, there's another type of white blood cell that actually has more to do with the adaptive immunity. Do you remember what the other type of agranulocyte is, the big category? The minute I say it, you're going to say, of course, that's it. Give it a shot. Be brave.
First initial.
Okay, there's two types of it, but lymphocyte are the other type of agranulocyte, lymphocytes, and there's two kinds. One goes to the thymus to be trained, so it is a T cell, right on, T cell, and the other is primarily in the plasma, and it is a B cell, right? B cell. B cells. All right. So these are all the agranulocytes. I'm going to mark for just a moment which of these are innate. So these are essentially innate. These are pretty much innate. These are part of the innate immune system. When I say innate immune system, what two characteristics come to your mind? Happens right away and non-specific, right. It's going to be the same response regardless of what invades. In addition, there's another type of agranulocyte, but we won't get into him. Now that's all the cells that are going to defend our body. I told you that there are components that are floating around in the fluid portion of the blood, and those include the complement system, which is a series of proteins that contribute to the immune response. Those are also innate. The clotting cascade, we're all real familiar with that, right? If somebody has inflammation, we will have hypercoagulability or increased risk of clotting. That's because of the initiation of the inflammatory response. That's also the innate response. Kinin is another system that leads to bradykinin. Have you heard that term before? That it's a cytokine that's used in the inflammatory process. It leads to vasodilation, so it's a part of the inflammatory process, bradykinin. And so these are also part of the innate immune system, which means happens right away, and it's non-specific. The same for every. Hello, Chief. So these are important components to keep in mind of the immune system with regard to the innate response. Now we're going to move into the adaptive response, I think. Okay, this is just a diagram that's going to tell us a little bit about what happens when there's injury or invasion by something that doesn't belong to our body. You'll see that there's injury and then mediators of inflammation. That's just a fancy way of saying chemical messengers. Remember I told you the mast cells live in the tissue of the respiratory tract? Here's an excellent example of what happens in the inflammatory response. I used to have hay fever when I was a little Peawadden, and when I lived by these fields that had ragweed. And whenever I would breathe in the ragweed, what would happen is that pollen would make itself known, and it would come to the surface of my mast cells, which were in my respiratory tract, and it would cause degranulation, which is simply a fancy word for saying the inside of that cell, remember this is a granulocyte, the inside of those granules will be released with things such as histamine and prostaglandins and bradykinin and substance P. All of these things lead to inflammation. And how did you tell me earlier we would see if I was inflamed? How would I know I was inflamed? What symptoms would you see in me? Redness, swelling, pain, warmth. All of that was happening on my face and my respiratory system because it was an inflammatory response to the presence of this invader, the pollen. And sadly, it happened just as school would start every fall. Bummer. What a crummy way to go into school. Red face, runny nose, not good. Okay, so that is an example of the innate response to an invader, an immune response. Leads to capillary dilation, which leads to the redness, that increased blood flow. Increased capillary permeability, which contributes to what sign of inflammation? If I have increased capillary permeability, what does that mean? Say again? I'm so sorry, I didn't hear you. Taking in is what you say? Taking into what? Okay, good. Swelling, taking into the tissues, essentially. So if I have capillary permeability is increased, what that means is the lining or the lining of the capillary is permeable. It allows things to leak out of the capillary into the tissues. So it's invading the tissues. That's what leads to swelling. I heard it over here. So the fact that I have increased capillary permeability as a result of histamines and bradykinins and some of those other cytokines, it will lead to the swelling and the extravasation of fluid, which means simply the fluid moves from inside the vessel to outside the vessel, right? We also see chemotaxic effect, which means when I have an invasion of something into my body, there are going to be chemical indicators released to the rest of my body to say, hey, we need help. And so it's going to cause white blood cells from around my body to come to that area to help. It's the first responders of the body, if you will. They come into that area so that they can phagocytize and take care of whatever the problem is. And then the systemic response would be, for example, if I have a prolonged, let's say I had an inflammatory response. During that inflammatory response, I breathed in a pathogen, a bacteria, that decided to make some trouble for me, and it released an endotoxin, which changed the set point in my brain so that I started to have a fever. I'd actually have an infection. That could also be a consequence of the inflammatory response. Does that make sense? These are all the second line of defense. This is still in the innate response. This is still the body's way of protecting from invaders on the second line of defense. We haven't even gotten into the adaptive immunity. Haven't even pulled out the big guns yet. Any questions about those? That slide? All right. Okay, this is just a review, response to the tissues of the body to irritation or injury. So the inflammation can either be because I have breathed in that ragweed pollen, or it could be because I stubbed my toe, a physical injury. Could be any of those things that could lead to it. Acute inflammatory response involves vascular and cellular components. Vascular simply referring to that change in the permeability of the lining of the cell, the vessels, allows things to leak out. And then cellular components, invitation of other white blood cells to come to the area to help. Okay. These are some of the components. Polymorphonucleo, or neutrophils, are just another way of saying neutrophils. What we've learned about these granulocytes is when there is an inflammatory response or an infection, neutrophils are some of the first granulocytes that show up. And so you may hear providers talk about a shift to the left. That's because they're looking at a lab result, and the neutrophils live in this part of the lab result. And so there will be a shift to the left, meaning there's an increase in neutrophils, which tells the provider this is a new infection, because those are the first ones to show up. So PMNs are what they're called, but it's just a fancy way of saying neutrophils. Cellular event sequence, at the local level, wherever the invasion has happened, those white blood cells are going to move to the side of the vessels, and they're going to start getting to work. They're going to first cause that permeability to increase. Then they're going to get into the tissue where they can actually make a difference for whatever's invading the body. And then they're going to call their friends and bring other white blood cells to the area. Cellular products of inflammation are cytokines, which is just cytokine means a chemical messenger, such as histamines, prostaglandins, bradykinins. Those are examples of cytokines. Interleukins, lymphokines. It just depends upon what their function is. Okay, I think that is. When we talk about wound healing, the inflammatory response is a big part of the healing process. So if we understand the inflammatory process and we have somebody whose wound is trying to heal, we can apply those concepts to recognize that needs to happen for this wound to heal effectively. Removal of damaged tissue through phagocytic activity, removal of inflammatory debris, restoration of the tissues to the normal state. There has to be an adequate blood supply to deliver oxygen and nutrients in order to rebuild the injured area. Regeneration of cells. Unfortunately, with many of the patients that we care for, the wound healing is impaired for one reason or another. So either the oxygen isn't there or the nutrients aren't there. What do you suppose would be some situations that would impair wound healing in a patient? Say again, infection. Brilliant. That's exactly right. Infection. If there's a wound bed that is infected, it will not heal until that infection is taken care of. Good. What else can impair wound healing? Okay, bacteria. Good, which can lead to infection, which is definitely going to quell the whole healing process. Remember I mentioned that we need oxygen and nutrients for the wound to heal. How do the oxygen and nutrients get there? Blood flow, yeah. So let's say I have some sort of a pathophysiologic condition where I have decreased blood flow. Maybe I have arteriosclerosis, or maybe I have really cold extremities, or maybe I have a situation where I'm sitting on an area that's decreasing the perfusion to that area. That's all going to delay the wound healing because it's not delivering the materials that are needed. What do you know about diabetics and wound healing? What comes to your mind? If you have a patient who has a wound and then you find out in their history that, oh, they have uncontrolled blood glucose, what do you know is going to happen to that wound healing? Delayed, you betcha. I talk to the nurses that I work with. It's almost like having a liquid petri dish. Because what do bacteria love to eat on? Sugar, right? And so if we have high blood glucose and that's what's feeding the wound, it's essentially providing snacks to the bacteria. And so it's difficult for the wound to heal if you have elevated blood glucose. So these are all factors that we as providers take into account when we're looking at somebody who has a wound, recognizing the concepts of inflammation and anything that can impair that natural wound healing trajectory. Does that make sense? Okey-doke. All right. Never a dull moment in healthcare. Have you noticed? Yikes. Okay, now the third line of defense is the innate included the physical barriers, which is the first line of defense, and inflammation, which is the second line of defense. Now we're going to step into the third line of defense, which is adaptive. Now, adaptive is different from innate. When I told you innate immune response, what were the two characteristics we talked about? Immediate and nonspecific. So guess what? Adaptive takes longer to happen, and it is exquisitely specific. I mean, it's just almost beautiful, the way that it's specific. And we're going to talk about that a little bit. The components of the adaptive system are primarily these, the lymphocytes and the immunoglobulins. I'm going to say adaptive to all of these little guys, with the exception of IgA has a little innate component to it. I'm so sorry to say, just to make things not so clear. So when I say immunoglobulin, if I were to break that word up, immune stands for immune system. When you hear the word globulin, what does that mean to you? It's protein, right? So immunoglobulins are simply proteins that live in our plasma that are natural personal antibodies. It's our own personal supply of antibodies. And except for IgA, they're exquisitely specific, meaning that they can be trained to identify specific invaders, and they get involved in part of the adaptive response. So we're going to talk about that in a moment. In addition, the lymphocytes, the T cells and the B cells, major components of the adaptive immune response. And we'll talk about how each of them responds in just a moment. Let's see here. An immunogen is simply something that stimulates the immune system to act. So, or an antigen is a synonym for immunogen. Anything that stimulates our immune system. So, for example, when I got my flu shot, when that came into my body, it stimulated an immune response from my immune system to start recognizing those flu virus, right? So that it can mount a campaign to fight off the next time the flu virus comes in. That's an immunogen. Make sense? Other antigens or immunogens would be antigens that live on the surface of the red blood cell. And it's why we always have to make sure that we type and cross a patient before we give a blood type, because there are immunogens or antigens that live on the surface of your red blood cell that my blood system may not like. And so, for example, I'm type O. I have no antigens on the surface of my red blood cell. I could donate to any of you without even knowing what your blood type is. I'm an O negative. I'm the universal donor. If, however, what is your blood type? Do you know? Who knows their blood type? A positive. Okay, good. A positive. If you were to donate your blood to me, I would be offended. My body would be offended by the A antigen and the Rh factor. And so my immune system would mount a campaign, and there would be all kinds of red blood cell destruction all over my body because it would be responding to the antigens of A and Rh factor. So an immunogen is not just necessarily a pathogen. It's anything that stimulates my immune system to go to action. Make sense? Okay. Alrighty then. We're going to take a break here in just 5 minutes, I promise. This is just an example of how an antigen, when it encounters an antibody in our body, it sets up the immune response. And we're going to talk a little bit more detail, so I'm not going to spend a lot of time on this slide. I do, however, want to talk about the different types of responses when the lymphocyte, which is one of the cells, the white blood cells, this is an agranulocyte, which means it has no granules in the cytoplasm. Lymphocyte is a specialized cell of the immune system that is either a T cell or a B cell. If a B cell encounters an invader, the B cell will respond by secreting all kinds of immunoglobulins, or IG, whichever immunoglobulin is going to be most effective against that invader. So B cells are considered part of the humoral immunity because when a B cell encounters an invader, it secretes antibodies into the fluid portion of our body. That's why it's called humoral. Humoral refers to the fluid. So a humoral immune response is when the B cells secrete immunoglobulins. Does that make sense? That's the way B cells respond. Completely different from when a T cell, now I'm a T cell, I'm a lymphocyte, but I'm a T lymphocyte. When I encounter an invader, rather than secreting immunoglobulins like my B cell cousin, I'm going to actually replicate and become a whole bunch of little T cells. And I'll be different types of T cells. I may be a helper T cell, I may be a cytotoxic T cell, or I may be a suppressor T cell. But it's going to be, I'm going to be one of those types of cells. That's my response to an invader. Are any of you Star Trek fans, by chance? You guys are probably way too young, but there was an early episode called The Trouble with Tribbles. Does anybody remember that? Oh, you guys are too young, holy cow. This was back when Captain Kirk was William Shatner, and they had these cute little furry things that came onto the Enterprise, and everybody thought they were so sweet, but they just multiplied like faster than rabbits. And so the trouble with tribbles, you'd open a cabinet and they'd come flying out, and you'd open a drawer and they'd come flying out. They were everywhere. I think of the trouble with tribbles when I think of a T cell response, because if I'm a T cell and I'm interacting with an invader, I'm just going to replicate beyond belief, and I'm going to become one of those types of T cells. Because I'm going to replicate into a different type of a cell, I'm considered the cell-mediated immune response. So I'm very, very important in the immune response, but I have a completely different mode of action than my B cell cousin. B cells, what do B cells do when they encounter an invader? Secrete immunoglobulins, exactly. And so that's why they're called what type of immunity? Humoral immunity, because it's secreting the antigens or the antibodies into the humerus, or the fluid portion. The T cell, when I encounter an invader, what do? I replicate. I become all kinds of different types of T cells, and therefore I am what kind of an immune response? Cell-mediated. That's exactly right. Both the cell-mediated and the humoral response are examples of adaptive immunity, because my B cell is going to be identifying, wait a minute, you don't belong in here, and it's going to look for a particular portion on the cell to see that, you don't have the passport that belongs here, and so it's going to have an initial response. But then it's going to go back to its headquarters and say, you know what, we need a task force so that the next time this guy shows up, we're ready for him. And so it will train B cells to recognize the next time, and so the next time that particular invader comes, it's going to be a much more powerful response because we've got troops that are trained to fight that particular invader. Same with T cells. They have memory. And when they first see something that doesn't belong to them, it's like, wait a minute, this isn't right. And there's a response. But then the second time that invader shows up, they are ready for them because they've got troops trained for that particular invader. So that's part of the adaptive. They're adapting to whatever the invader is. Hence the name adaptive immunity. Okie doke. I think it's time for us to take a break. Let me see if we're there. These are just examples of, this is the humoral immunity where the B cells will release antibodies into the humerus or into the plasma, compared with T cell or cell-mediated adaptive immunity, which they will replicate, the trouble with tribbles, and they will fight the invader in a different way. Okay, why don't we go ahead and take about 10 minutes. If you come back at 10 after, we'll pick up our discussion by talking about what happens when our body overreacts. either to inflammatory response or the immune response. Okie doke? Thanks. Am I picking up okay? Have there been no questions come in?
So for KCFR, I sent out the email. Just make sure you go into the W drive and have the dates for your CPR research, your TB, and your flu shot. You'll have to go through your training records to see when the CPR was. And if it's more than a year old, you'll have to do CPR really quick. But just make sure you go up there and put the dates on there so I can send that to Scott.
And the TV's done at our annual with Dr. Gibbon. And you should all have to have you'll have to have a flu shot before you go to cooking. All right?
Let me know if you have questions.
All right. So you, Janet Lee, you ready?
I can. You betcha.
Anything for me before?
Take it away.
Alrighty then. Great question during the break. Was talking about a question with regard to the inflammatory response. And I wanted to make a point to make sure that everybody was real clear. The way we are designed, the inflammatory response is designed to protect our body, as is the immune response. It is all to protect our existence, which is pretty amazing. For example, when I use the example of when I was little and I had hay fever, and I would breathe in ragweed pollen, I would have this inflammatory response. The purpose of that inflammatory response was to keep the pollen from getting all the way down to the alveolar capillary membrane, which is where gas exchanges in my respiratory system. So all of that inflammation was all designed to protect my alveolar capillary membrane from the invasion of that pollen. Beautiful design. The problem is when the inflammatory response also cuts off my oxygen. Oops, that's a problem. So that's why we sometimes have to intervene when the inflammatory response threatens a person's life. Even though it is designed to protect the body, there are times where it overprotects, and we have to intervene. Same with the immune response. Normally, the immune response is going to take care of any invaders, and if it doesn't, we administer antibiotics. Exogenously. We may give Keflex or something that to help our own immune system. But there are times when it goes awry. Is everybody real clear on that? Okay, so it really is a beautiful design. It's only when things go a little bit too far that we get into trouble. For example, hypersensitivity, that is when the inflammatory response has gone too far. For example, type 1, which is the one that probably you all will deal with the most, I would anticipate. Type 1 hypersensitivity reaction, an example would be anaphylaxis. Yikes, which can lead to anaphylactic shock. That is a type 1 hypersensitivity. It's when our own body's defense mechanism has gone overboard and it's threatening the life of the person. There are 4 levels or types of hypersensitivity reactions. Type 2 is a cytotoxic hypersensitivity, and that's the one that I was talking about with the incompatibility of a blood transfusion. That would be a type 2 hypersensitivity, just a little bit different mode of action. Type 3, this is one that is more like rheumatoid arthritis, more like a chronic or glomerular nephritis. It is our immune system working overboard. And then a delayed type 4 hypersensitivity would be, I know I work with a lot of nurses that have contact dermatitis to, what do we say again?
Latex.
Latex, yeah, that's exactly right. Latex allergy, that's a type 4. It's a delayed, it's happened over time. So they're categorized based upon how the body responds to the invader. And we have to intervene when it threatens the life, obviously. And the one that I anticipate you will see the most would be type 1, which is anaphylactic. This is just a great visual. I think, are they going to have access to this PowerPoint after?
Yes.
Okie doke. So this would be something for you to go back and just kind of help understand what's happening in the body. It follows the flow of what we've talked about with regard to the inflammatory response, but it shows how it gets a little overboard. There can also be problems when our immune system, not just the inflammatory response, but the immune system has gone awry. For example, autoimmune disorders. We're learning more and more that some of the disorders that we never knew before, they're actually an autoimmune disorder. What does it mean to you when I say autoimmune? Autoimmune means, what is an autobiography?
Your body creates it. Autoimmune disease is like something that your body's creating.
Brilliant. That's exactly right. So auto meaning self-generated. That's exactly right. So autoimmune is when the immune system starts attacking your own body. For example, rheumatoid arthritis is an autoimmune disorder. We've now learned it's when our immune system, something goes awry, and it's like our T cells are really worked up, and they're going after the invaders, and then they take care of all the invaders, and they're like, I still got fight in me. And so they're going to start attacking the joints. That's rheumatoid arthritis. We've learned, research just recently has revealed that type 1 diabetes is an autoimmune disorder. Normally, the immune response will fight an infection, but then if it takes care of the infection and it still has fight in it, it's going to go to the B cells in the pancreas and start destroying those, leading to type 1 diabetes. Isn't that remarkable? I think back to all of the pediatric patients that I cared for who were diagnosed with diabetes type 1, and almost without fail, I can have the parents respond with, you know, they had this horrible infection about 4 months ago or 7 months ago that preceded the symptoms of type 1 diabetes. And sure enough, it was probably that infection that started the ball rolling, and the immune system just kept going. And after it took care of that infection, it started going after the B cells. So that's an autoimmune disorder. A lot of the endocrine disorders, Graves' disease, which is hyperthyroidism, or even Hashimoto's thyroiditis, which leads to hypothyroidism, those are considered autoimmune disorders. On the other end of the spectrum, we can either have the immune system that's gone overboard, or we can have an immune system that has failed us, such as human immunodeficiency virus. It attacks those helper T cells, making our immune response inadequate, and can lead to AIDS. That's a progression. Not all HIV positive lead to AIDS, by the way. Thankfully, now HIV positive is no longer a death sentence as it was in the 80s and 90s. But the response is that the person's immune system is tremendously impacted and depressed as a result of the activity of that mean little virus, HIV. SCID is another form of immunodeficiency. Some of the cancers that affect our immune cells, such as leukemia, are immunodeficiency, can lead to immunodeficiency. So when you're taking care of a patient and you are getting the history and you find out that they have a decreased immune response, that's going to dial up in your provider mind, oh, that means that they will not be as well prepared to fight off an infection or to fight off this assault as you or I would be. So we need to factor that into our care of these patients. So it's a beautiful design, but we do not live in a perfect world, and so our bodies don't always respond just exactly like we want them to. And these are some of the problems that can happen when they go awry. Here's a couple of practice questions just for kicks. Remember we talked a little bit ago about what an immunogen is. It is a blank, capable of generating an immune response. I want you to look at the options and I want you to commit to how you would answer that. Have you selected one? Have you committed? I'm not going to make you tell your neighbor, but if you were in my class at school, we would. Okay, the best answer would be an antigen. So an antigen is anything that elicits an immune response, okay? An immunogen is just a synonym for antigen. Okie doke. All right. This is going to take us into the next section. I don't have a really good segue for this, but another real important concept for us to wrap our brains around as we're taking care of patients are imbalances in our patients with regard to fluids, electrolytes, and acid base. Now, we could pretty much spend a day on each one of those, but we're going to we're going to take a little tour through these together. Okay, first of all, just a little bit of a reminder. Remember that approximately for us in this room, about 60% of my body weight is due to water. Isn't that remarkable? The younger the child is, the greater the percentage of body water. Now, what do you suppose that means practically? Knowing that the younger your patient is, the greater percentage their body water, what does that tell you as a practitioner? Anything in particular? Okay, that could be part of the reason, because they don't have their organs aren't functioning to full steam yet. Good. What else?
Dehydration would be a big concern.
They are at much greater risk for fluid imbalances, dehydration or fluid volume excess. That's so very true. So when you're taking care of pediatric patients, fluid balance is very, very important. I might add that's true of the older population as well, for different reasons, but at both ends of the age spectrum, fluid balance is in danger. So we need to keep that in mind as we're caring for those parts of the population. Now, the fluid in our bodies are in one of two major compartments, either intracellular, which means it's inside the cell membrane of each of the cells, intracellular, or it's extracellular. And extracellular can be divided into intravascular, which means it's inside the vessels, or interstitial, which means it's somewhere between the cell and the vessels. Okay, so let's keep those compartments in mind. That's where the fluid's supposed to be metabolically available for the functioning of our body. Okay, so with that as an intro, the balance of the fluid within those compartments are based on a couple of concepts. Well, there are a couple of pressures that are going to determine whether the fluid's moving into or out of each of those compartments. And we are designed to have a particular percentage in each of the compartments in a normal, healthy person. Hydrostatic pressure, when you hear hydrostatic, I want you to think, how appropriate, of a fire hose. Think hydrostatic pressure because it's pushing. So hydrostatic pressure is anything that's pushing fluid. An example would be if I have an elevated blood pressure, that hydrostatic pressure is going to motivate the fluid out of my vessels into the tissue because it's pushing the fluid out. You with me? That's it's balanced by what is called osmotic forces. Osmotic, rather than hydrostatic being a push, osmotic is something that pulls. So the presence of particular molecules inside our vascular system motivates the fluid to stay in the vascular walls. Do you have any ideas what some of those molecules might be that float around in our plasma that keeps the water in the vessels? Okay, sodium, good. Sodium is a good one. What else? Say again? Magnesium is going to be a really important component of mostly bones and teeth. So it'll impact those tissues mostly. Same with calcium. They kind of live in the bones and the teeth. That's a true statement. I'm not asking the question right, I'm so sorry to say. Inside our plasma are proteins, primarily albumin is like one of the major plasma proteins. And a protein is going to pull the fluid in just like sodium will. It's going to pull the fluid into the space. When you were little, when you'd go on road trips with your parents, if you'd stop at a diner and you get kind of bored, did anybody ever put salt on the table and then take a little bit of water in a straw and put right beside it and see what happened to the water? Did anybody ever do that? Well, if you haven't, you need to do it because it's a pretty fun little thing. I'd always get in trouble when I was camping with my family. But I would put a little salt there, and then I'd put just a little drop of water right next to the pile of salt. What happened to that water? Yeah, it was pulled to the salt. The salt didn't go to the water, but the water went to the salt. That was an example of osmotic pressure. And that's happening inside our bodies by the presence of sodium chloride, and also the presence of proteins, plasma proteins, primarily albumin. So consequently, if I have a normal level of albumin, the fluid portion of my blood is going to stay in the vessels. What would happen if I have malnutrition and I have decreased albumin? What would happen to the fluid portion of my blood? Yeah, it's no longer going to be motivated to stay in the vessel walls, and so it's going to be kind of like, oh, there's nothing happening here. Oh, what's happening over there? And it will leave the vessel walls and go into the tissue. And it will present a symptom that I know that all of you have seen, or a sign that all of you have seen, edema. One cause of edema is a decreased albumin in the serum because there's no reason for the fluid to stay in the vessels, and so it leaks into the interstitial tissue. So I want you to always think about the hydrostatic versus the osmotic pressures, because they're always at play to keep the fluid in the compartments that they're supposed to be. And what were the two major compartments for fluid? Okay. Intracellular and extracellular. And in the extracellular, there was intravascular and interstitial. Very good. That's exactly right. So kind of keep in mind, that's where all of the fluid should be in our body. Now, if there's fluid in other compartments, does anybody know what that's referred to as? Third spacing. I don't know if you've heard that term before. An example of third spacing is when the fluid is not in one of those three compartments that we just talked about, but instead is in a compartment where it is no longer metabolically available to help the body. An example would be, have you taken care of patients who have liver failure and they have really big bellies because of ascites, accumulation of fluid in the abdominal cavity? That's a classic example of third spacing. So we may have somebody with increased fluid, but they may have decreased blood pressure because they have decreased fluid in their vascular space, but overall more fluid in their body, but it's all accumulating in their abdomen. That's considered third spacing. Clearly a pathophysiologic phenomenon. In a healthy person, they should either have fluid in the cells, or in the vessels, or in the interstitium. Okay? Alrighty then.
Would you consider lungs, reaction to CHF as third spacing?
Great question. That's actually, it's in the tissues in that case. Third spacing with regard to the lungs would be if I had a pleural effusion. So outside of the lungs, but in that pleural cavity, not supposed to be there. While it's in the lungs, it's going to impair the gas exchange, but it's in the tissues. So it's in the interstitium, if you will. Good question. Any other questions about that? All right, for those who are online, the question was, would fluid accumulation in the lungs, like from a pneumonia, for example, be considered third spacing? And in reality, it's not third spacing, but it is certainly going to interfere with the gas exchange. A type of third spacing in the lungs would be a pleural effusion, where there's fluid in between the lungs and the thoracic cavity. It's not supposed to be there. Okay, alrighty. Okay, disruption of homeostasis can cause or exacerbate various disease processes. So we could have a change in the fluid and electrolyte balance based on a pathophysiologic condition, which we'll talk about a little bit. The degree of fluid imbalance required depends upon the patient's size, their age. We talked about at the extremes, they're at greater risk for fluid imbalances, and any underlying medical condition. For example, if a patient has pneumonia, that's going to impact their fluid balance because they have too much fluid in their tissues, in the interstitium, and it's going to interfere with the gas exchange. Another example would be if somebody has heart failure. What is heart failure? Failure of the heart, sorry. Give me a layman's term, what is heart failure? Say that again. Ineffective pumping, that's exactly right. If I were your patient and I said, okay, I was diagnosed with heart failure, what the heck is that? You would tell me your pump is not efficient. That's exactly right. Your heart is not pumping efficiently. If a patient has heart failure, that's going to lead to a backup of fluid, and it's going to lead to an imbalance between those three compartments because it's not efficiently moving it the way it's supposed to. So pathophysiologic disorders and diseases can impact fluid balance. All right. The two major differences, just major categories of fluid volume imbalance, are either overall fluid volume deficit or fluid volume excess. As you can imagine, fluid volume deficit means that there's a decrease in the fluid, in this case the extracellular fluid, and your book talks about isotonic fluid volume deficit, which simply means there's a decreased amount of fluid and sodium equal. We're not going to get any deeper than that, but there are hypertonic dehydration and hypotonic dehydration, depending upon whether you're losing salt and or fluid. But we're just going to talk about fluid in general. Fluid volume deficit means when you don't have enough fluid on board. Fluid volume excess, of course, would be the opposite, where there's too much fluid in your body for normal functioning. Fluid volume deficit is also known as dehydration. The causes can be from a number of different reasons. Either you've had a patient who's had several days of vomiting and diarrhea. That will lead to fluid volume deficit. You may have somebody who has third-degree burns over a significant percentage of their body. They're going to lose fluid because of the shifts. You could have somebody who's on diuretics that have not been controlled and they haven't needed it, and so they're losing too much through their kidneys. That can lead to dehydration. How will you know if a patient has dehydration? What kind of assessments do you see in a patient who's dehydrated? Dry mouth. Very good. That's a great place to start. Say again? Good, good. So your skin turgor is going to be delayed because you've lost that fluid portion. Good. Say that one more time.
Like the difference in your blood pressure from sitting and standing.
Good. Okay, so you're going to, because you don't have enough volume in the intravascular space, your blood pressure is going to go down, right? So normally you have a decreased blood pressure, and it's certainly going to be exacerbated if you change positions, whether the autonomic nervous system is working or not. So you're talking about orthostatic hypotension. What about your heart rate? If you have a decreased blood pressure, your heart rate goes up. Yeah, these are all signs of dehydration. And if you're suspecting it, I encourage you to gather that data to kind of make your case. This is what we've got going on, dehydration. Very good. Water and electrolytes are lost in the same equal proportions, also known as hypovolemia. It's going to lead to ultimately inadequate tissue perfusion, and we're going to talk about a type of life-threatening hypoperfusion that results from decreased volume in your body. Symptoms include headache, thirst, dry skin, dry mucous membranes, elevated temperature sometimes, weight loss because you've lost that body weight. Remember, what percentage of the body is fluid? 60%. So if you're dehydrated, you're going to get rid of part of that 60%, right? You'll see concentrated urine because your body is going to hang on to as much fluid as it can, and the urine that you do put out is going to be much more concentrated. If you're taking care of little Pewadans, you'll see that their fontanelle, in between their skull, is going to be depressed. Okay, good, good. Oh, gosh, am I going right to fluid volume? I think I am. Come on, baby. Okay, well, I guess we're moving into fluid volume excess. So where fluid volume deficit, we've got a pretty clear picture of a patient who's dehydrated. Fluid volume excess is just the other way. Think of them, they'd squish if they were walking. There's too much water. There's too much fluid in their body. The symptoms that we see with fluid volume excess would be just the opposite. Elevated blood pressure. Why do we see an elevated blood pressure with fluid volume excess? More fluid in the vascular space in particular. Right, so it's going to be more pressure for the pump to pump against. Good, good. Increase in weight. You may see JVD, jugular vein distension, narrowing of the pulse pressure, so the difference between the systolic and the diastolic will be less. Bulging fontanelles in the infant. Ascites is what we were just talking about with regard to third spacing, where there's too much fluid in the abdomen. Confusion, and that all has to do with the movement of fluid in the intracerebral cells, which we'll talk about in just a moment. Can lead to seizures, shortness of air, crackles in the lungs. I remember I worked with this wonderful mentor one time where she said, Janalee, if you don't have enough urine output for your patient, if the fluid's not leaving the body, it's going one of two places. It's either going into the tissues or it's going into the lungs. So those are the two places I need to focus on checking for. Okay. Fluid volume excess. Accumulation of fluid in the interstitial spaces is a particular type of fluid volume excess that we all know as edema. You bet your boots. The balance of filtration and reabsorption between the interstitial fluid resulting in an abnormal expansion of the interstitial fluid. The causes for this, now this is going to go back to those terms that we just talked about. Think about this with me for a moment. What was hydrostatic pressure? Pushing. What was osmotic pressure? Pulling. Thank you very much. So if we have somebody with fluid volume excess who is experiencing edema, it's going to be due to one of these or more of these reasons. Increased capillary hydrostatic pressure, because just as you said, there's too much volume in the intravascular space, increasing the pressure, the hydrostatic pressure in the intravascular space, which is going to motivate the fluid to go out of the vessels into the tissues, right? Could be decreased plasma oncotic or osmotic pressure. What could lead to a decreased plasma osmotic pressure? Say again? Lack of sodium. Very good. Lack of sodium or the albumin, decreased albumin. That's going to decrease the oncotic or the osmotic pressure of the plasma. Increased capillary permeability. Well, what state did we just talk about that increases capillary permeability? Inflammation, you bet. So if I've got a patient who's got anaphylactic response, for example, I'm going to have increased capillary permeability, which means the fluid is going to be free to go explore the tissues, right? Another cause can be decreased lymphatic drainage. We haven't really talked about the lymph system, but the lymph system is a very important way to get the fluid that has left the vascular space back into the vascular system. If we don't have the lymph system, we would lose all of our fluid in a matter of minutes. It's really quite remarkable. You may have taken care of patients who have had a mastectomy that had a lymph node dissection. And what do you see on that limb? Say again?
Puffy.
Puffy, right, edema. That's called lymphedema. That's exactly right. And the reason for that is because we've lost that mechanism of removing the fluid from this tissue, because we've lost that lymph system if they've had a lymphadenectomy. Very good. That's exactly right. Okay, so all of those things can lead to edema. And here's the, everybody, all of us in here have probably seen edema. It's either generalized, which is anasarca. That is more when it's due to something like malnutrition or decreased albumin of some sort. Dependent is much more associated with heart failure, the lack of ability to move the fluid around properly. And if it is dependent, that means it's dependent on gravity. So whatever part of the body is lowest is going to be edematous. Whether if they're laying on their back, it'll be their sacrum. If they're sitting up in a chair, it'll be their lower extremities. So think about where, sometimes I've taken care of patients with dependent edema. They're laying down, but when they're on this side, they've got edema on this side of their body. When we turn them over, the edema goes to this side. That's a dependent edema. And then sometimes we see localized edema. If you have a patient on the sports field who has sprained their ankle, that'll be just in the area of the damage, localized. Okay. So some comparisons as you're making a judgment call in the field when you come upon a patient with a fluid imbalance. I thought it would be helpful to keep in your mind how these two compare. Fluid volume deficit, aka dehydration. Fluid volume excess on the other side. So cardiovascular, we already talked about how you'd see increased pulse rate, decreased blood pressure. You wouldn't have JVD, but flat neck veins. Decreased central venous pressure, probably increased rate and depth of the respiratory rate. Why do we see an increased rate and depth of respirations with dehydration? What do you think?
So since the cylinder's empty, it's trying to increase output through rate.
Exactly. And primarily it's trying to, the response was that it's trying to maximize the delivery of what component in the blood? Oxygen, you bet your boots. And so if a patient is dehydrated, that means they don't have adequate perfusion. You're absolutely right. And they're not delivering the oxygen. So your body is like, holy cow, we need more oxygen because we're getting too much carbon dioxide. So it causes you to increase your respiratory rate. Very good. On the other side of the coin, fluid volume excess, we see bounding, increased pulse rates. We see elevated blood pressure, JVD, increased rate, shallow depth. Now, the reason for increased rate with fluid volume excess might be what? Say again? Trying to output more. You're right, the body is detecting still that there's not adequate oxygen to the tissues, but what in the case of fluid volume excess could interfere with that delivery of oxygen? Where did I tell you fluid goes if it's not leaving the body? Fluid in the lungs, you betcha. If there is fluid in the lungs, then it's not being distributed to the body. And so again, your body's going to say, holy cow, we need more oxygen. And so it'll increase the heart rate. So the respiratory rate. So you'll see an increased respiratory rate in dehydration, and sometimes you'll also see it in fluid volume excess. So that's not one to pin your hat on. Dyspnea, moist crackles, really important assessment if you have a patient who's fluid volume excess. Make sure you assess their lungs. With regard to neuromuscular and the deficit, there's lethargy and coma due to the change in the cells in the cerebrum. Sometimes you'll see a fever, weakness, decreased output, of course, from your kidneys, decreased body weight overall, and you already talked about the delayed skin turgor deficit. Now with excess, we also see altered LOC, but it's a completely different mechanism, also to do with the change in the cells of the cerebrum. Headache, visual disturbances, again weakness. You could see an increased output if the kidneys are functioning. If the kidneys are damaged, however, if you have renal failure, which is causing the fluid volume excess, you'll have a decrease. So you have to think about what's happening with your patient. You'll see an increased body weight, and you'll see that edema. Now, why would your skin be pale and cool with fluid volume excess? What do you think?
Fluids interfering with capillaries.
Yes. If the fluid is in the interstitial space, it's not going to allow the periphery, the vessels to get there, right? Brilliant. That's exactly right. So you'll often see your extremities very cool and pale because you're not getting the blood flow. Very good. Okay. Last slide on this, comparing with regard to fluid volume deficit. You'll see an increased serum osmolality. I'm going to sit on this one for just a moment. The next section we're going to talk about are electrolyte imbalances. One of the main electrolytes we look at is sodium. Whenever you think of sodium, I want you to always think fluid balance, because that's the first electrolyte to go to when you're thinking about fluid. And if I say there's increased serum osmolality, that means there's increased serum content in the serum. That doesn't mean that you have more salt or sodium in your body. What does it mean instead? There is an imbalance, yes. So remember that sodium and water are sort of inversely proportional. So if I have decreased fluid, it's going to look like I have an elevated sodium because I don't have enough water. And the reverse is true. If I have a decreased serum sodium, it's probably because I have too much fluid, not because I have not enough sodium. So whenever you think sodium, think fluid balance. Really important indicator. With fluid volume deficit, you also see dilutional increase in hematocrit, blood urea nitrogen, and serum urine-specific gravity, just because you're not releasing as much fluid. And then on the other side of the coin, fluid volume excess, you see a decreased serum osmolality because you have more fluid than you do electrolytes. You have a decreased hematocrit, decreased BUN, again because of the dilutional factor, decreased urine-specific gravity, assuming that your kidney is functioning. Any questions on those comparisons between how a patient will present with fluid volume deficit versus fluid volume excess? All right, good, good. Kind of a crash course, but really major concept when we're taking care of patients. Let us step now into the world of electrolytes. Your book covers, I think, 5 electrolytes. I'm going to spend most of our time today talking about sodium and potassium, because those are the ones that are pretty critical. The others that are dealt with in your book are calcium, magnesium, and phosphorus. And so I'll touch on those. But when we're taking care of patients, you really need to key in on sodium and potassium when you're looking for the well-being of your patient. So let's spend a little bit of time looking at those. Sodium is the primary extracellular electrolyte. So if I were to draw a cell here, sodium would be on the outside. It's primarily on the outside, which is good because when I draw a serum sample and I'm looking at a serum level of sodium, is that intracellular or extracellular? Extracellular, you betcha. Whenever I'm drawing a venous sample, I'm always measuring the extracellular. That's what I have access to. It is 90% of the extracellular fluid. We'll talk a little bit more about the details on this one. Hyponatremia. So the normal levels for sodium in the serum are 135 to 145, essentially. So sodium deficits cause decreased plasma concentration and cellular swelling. Remember, whenever you think of sodium, I always want you to think of fluid. And when we talk about cellular swelling, let's see if I can draw this real quick. This is kind of an important concept. If we think about, here's my vessel. This is the capillary. And then this is my cell that lines the capillaries. And then I've got interstitial space in there. You with me? Remember that sodium primarily lives on the outside of the cell, right? If I have increased sodium in here, more than normal, what direction will the fluid flow? You betcha. It's going to go into the vessel, which is going to cause my cell to shrink because it's going to try to dilute the intravascular sodium to make it a normal osmolality. So if I have too much sodium, it's going to pull water from my cells, causing cell shrinkage. That's what leads to the neurologic symptoms in a patient who has an electrolyte imbalance, by the by. Very common among hospitalized elderly because of, sometimes they're on low sodium diets. Sometimes they have too much water, or they may be on medications that's going to alter their fluid balance. And so dehydration is not an uncommon thing to see. Low sodium is not an uncommon thing to see. Alters the cellular's ability to depolarize and repolarize. And so you're going to see lethargy because of the change in the cells in the central nervous system. But you're also going to see a change in the reflexes because sodium is very important in the action potential, for the neuromuscular action potential. Can't even see seizures and coma. Hyponatremia. Okay. I'm sorry, this is hypernatremia. I'm so sorry, I made that confusing. Hypernatremia is when there's increased sodium in the vascular space, and that's what causes the cell to shrink. If, however, we have, let me do it on the same page so it's not confusing, or it's less confusing. If we have the same situation, but now we have decreased sodium in the vessel, so there's hardly any sodium here, but holy cow, there's all kinds of sodium out here. What direction will the fluid go? Toward the cell, and it's going to lead to a puffing out or a swelling. So with hyponatremia, we have cellular swelling because it's going to not keep it in the vessel, but instead go into the cells. You with me? If I have dehydration, which is what I drew up here, that's going to pull the fluid out of the cells and into the vessel, causing cell shrinkage. These are really important concepts when we think about giving IV fluids to a patient, right? Because when we give IV fluids, we're giving it into which compartment? Intravascular, yeah. So if I give just into a general, if I give, there's isotonic solution, which means what? Iso means the same, right? So isotonic solution is essentially the same tonicity or concentration as our body fluids, isotonic. So if I give isotonic, it's just going to stay in the vessel because it's the same as the rest of the body. If, however, I give a hypertonic solution, hypertonic, let's say that means it has lots and lots of sodium or has lots of crystalloids in it. What's that going to do to the movement of fluid? You better believe it. So it's going to cause cell shrinkage, and it's going to increase the intravascular volume. This is a tremendous thing to do for a patient who is fluid volume deficit, and we want to ride it. We want to pull more fluid into their vessels. That's a great idea. Or if we have a patient who has these edematous cells, and we're trying to fix that, we want to move the fluid out of the cells into the vessel, right? And so a hypertonic solution has its place. If, by comparison, we give a hypotonic solution, meaning I'm going to give something that doesn't have a lot of solute in it. What direction will the fluid go? Yep, it's going to go into the cells. So what might be a clinical situation in which a hypotonic solution would serve my patient well? Okay, burns, because I'm going to need to replace what is lost in the cells. Exactly. So anytime I've got a patient who has dehydration, and I've got shrinked of cells, I want to increase those cells by giving a hypotonic solution, moving the fluid out of the vessels into the cells. Are you with me? Okay. The reason that I'm talking about this now.
Just so you know, we're adjusting the camera for those that are watching.
Oh.
To put a little bit more on your chart.
Okay. Thank you. The reason I'm talking about this with sodium is because sodium is so closely tied to fluid balance. And we need to pay really close attention anytime there's an imbalance in fluid or an imbalance in sodium. When we write those, we do it very gradually because we know that whatever we put into the vessel is going to have a direct relationship to the size of the cell. And I don't want in my brain, I don't want my cells to shrink too quickly, and I don't want them to get rehydrated too quickly, or it causes neurologic problems. So we always alter fluid balance very, very slowly for that reason. Okay, I think I digressed just a little. Hyponatremia can be caused from a number of different reasons. If you have a patient who's been vomiting for several days, or if they're on NG suction and not replacing that fluid, if they've been on diuretics and they're losing fluid that way, that includes the sodium loss, because that's how most diuretics work, by decreasing the sodium. Or it could be from a patient who's just run a marathon and they've lost a lot of sodium from their sweat. What we see much more often in the acute care setting are dilutional hyponatremia, meaning that there's too much fluid on board. Not that they've really lost too much sodium, but because there's too much fluid on board. Okay. The signs and symptoms of hyponatremia, a lot of neuro, but also seizures and coma. These are some of the causes of it. And anytime we want to treat it, it's going to be to restore the balance very gradually. We could give a hypertonic solution, such as in this case, which is going to cause the fluid to go back into the vessels. But we're going to do it very, very slowly, watching the neuro response. Okay, so now let's go to the other end of the coin. We've already talked about, when you think of sodium, you think of what? Fluid, thank you very much. When you think of serum sodium, you think fluid balance. If there is too little serum sodium, you know that there's what? with regard to fluid balance. If there's too little sodium, too much water, right? Fluid volume excess. If, on the other hand, there's too much sodium, what do you know about the fluid balance? Too low, right? So you kind of think of dehydration, right? Because almost always it's due to dilutional factors. The movement will be from the intracellular to the extracellular fluid. The symptoms include any symptom that you talked about earlier with dehydration, confusion, still because of the change in the cells in the CNS. Could be pulmonary edema, tachycardia, muscle twitching. Some of the causes for hypernatremia, if there is an endocrine disorder called Cushing syndrome, which impacts the adrenal cortex and causes oversecretion of aldosterone, because remember, aldosterone is what causes the kidney tubules to reabsorb sodium. That's going to lead to too much sodium. If there's too much sodium intake via IV, that's why the provider is very careful about what IV solution is being administered and at what rate. We watch that very carefully. On rare occasions, and I've only seen it in mental hospitals, would be large amounts of dietary intake. Most people can't tolerate too much sodium without taking in water as well. Diabetes insipidus, which is another endocrine disorder of ADH, that would also lead to a problem with too much sodium. Could be because of renal failure, inability to concentrate the urine, and age-related changes to thirst. Okay, this is kind of what I was drawing up here, but this just shows if you have hypernatremia, that means you have more solute in the vascular space than you do in the other two spaces, which it motivates the fluid to go into the intravascular space. If you have a patient with too high of a serum sodium, that means it's above 145, we will gradually correct it. And why do we gradually correct this imbalance? What are we concerned about? Neurologic response, you betcha. Because when we change the sodium, it's going to impact the size of the cells in the CNS. That's what we're worried about. Good. Okay. That brings us to potassium. However, I think this is a good time to take a break. You ready for a stretch break? If you could come back at about 10 after, we'll continue our discussion about potassium and it'll lead it into the other electrolytes.
Pete, how do I pause the teach me, oh wise one?
Say his name and he appears. We have a couple minutes before it's 10 after. Mm. Mm. All right. Thank you. Mm. Mm. I want to give folks time to get back in. I told them 10 after, so I don't want to. Well, I know, but there are empty spots. I don't want them to feel like they're invaded.
We lost a crew to a call.
Oh, we did. Oh, okay. I guess I won't wait for them. Got it. All right. Well, we're going to go ahead and dive back into the electrolytes. So far, all we've really talked about is sodium. Do you remember what the normal values for sodium are? 135 to 145, brilliant. And that is serum sodium, so that means extracellular sodium. And when you think of sodium balance, what do you automatically think it's related to? Fluid balance, you bet your boots. So if I have a sodium of 152, what do I anticipate my fluid situation to be? Deficit, yeah, fluid volume deficit. Conversely, if I have a low serum sodium, say 134, what do I anticipate my fluid volume to be? High, yeah, which is probably being reflected there. So if you remember the normal values, and always remember sodium is a reflection of fluid balance, you're golden, hot dog. The next electrolyte I'd like to spend a bit of time on is potassium. And one of the first things I want you to recognize is the range, 3.5 to 5.0, pretty narrow range. Anytime you see something with a narrow range like that, you need to recognize that anything outside of it, just a little bit, is going to be a pretty big deal. Whereas 135 to 145, I had 10 metrics, right, in between. This one I have 1.5. So this is going to be a much more delicate balance, very, very important. And where sodium was the primary extracellular electrolyte, potassium is the primary intracellular electrolyte. So when I'm measuring serum potassium, am I measuring intracellular or extracellular? Extracellular, yeah, because it's intravascular. So I'm not really looking at intracellular, but I do know the correlation, and I'm basing my clinical decisions on what I know is normal. But it's important for us to keep that in mind. We're looking not at the intracellular potassium, we're looking at the extracellular when I get a serum sample. Okie doke. The balance is maintained primarily through the sodium-potassium ATPase pump, because after there's any action potential, it is that sodium-potassium ATPase pump that gets everything back in order. In other words, moves the potassium back into the cell to get it ready for the next action potential. Very important piece of information, primarily because if we don't have ATP, which is energy, that means that pump is going to fail. That pump is going to fail, and it's going to interrupt the availability of the action potentials. Very, very important. It also has a role in acid-base balance, which we'll talk about next. The primary takeaway whenever I think cardiac and I'm thinking of patient care, when I think potassium and I think of patient care, I think cardiac. If I have a patient with either too much serum sodium or serum potassium or too little serum potassium, I'm worried about their cardiac function. Now, there are other signs and symptoms that they're going to have problems with too, but nothing more life-threatening than their cardiac function. So whenever you see a potassium that is out of whack, clinically you need to think, I need to see what's happening electrically with this cardiac function. So you need to make sure they're on telemetry. Make sense? Okie doke. The body adapts pretty slowly to potassium. Just with, as we talked about with sodium, if there is an imbalance in potassium, we don't just, if there's too little potassium, we don't just flood them with potassium. We have to do it slowly so that it doesn't overexcite the cardiac cells. The kidney is the primary regulator of potassium because it will either hang on to potassium or let go of potassium based upon the acid-base balance and the sodium balance. Okay. If we have a patient who has hypokalemia, that means they have too low serum potassium. Some of the causes could be diuresis. For example, what is a primary loop diuretic that is given to almost everybody with heart failure? Lasix, you bet your boots. And if a patient is taking Lasix, they better be taking a potassium supplement or they're going to have hypokalemia. It's just a known fact. So it's really important for us to keep that in mind. And it has to do with where the Lasix works on the ascending loop of Henle, because that's also where the potassium is reabsorbed or not if they're on a diuretic. Another example would be too much aldosterone. For example, if a patient has Cushing's syndrome, or glucocorticoids. That's interesting. Glucocorticoids would be something like a steroid that's given, right? Increased entry into the cells. We'll talk about that a little bit with acid-base balance. Increased loss of body potassium, which we'll talk about in a moment. Treatment of DKA. What does DKA stand for? Diabetic ketoacidosis. That is your wheelhouse, you guys, I know. Interestingly enough, if a patient has really supersonic high glucose and they are in DKA, we of course need to bring that glucose down, right? And so how do we bring the glucose down? We give insulin, you betcha. I mean, that's the normal way to do it. We will bring the glucose down by giving insulin. Interestingly, as insulin moves the glucose into the cell, guess what else it moves into the cell? Potassium. And so we have to make sure we know where the potassium level is, because if it's low normal, this patient will soon be hypokalemic because of the action of the insulin. So we kind of need to keep our eye on that with DKA. There's a very intimate relationship between insulin and potassium. Okie doke. Diaphoresis, wound drainage, poor intake, of course. GI losses is one of the major causes that we see outside the hospital. Diarrhea, laxative abuse, or prolonged vomiting. You really lose more potassium when you have more GI suction or vomiting. You lose more of the alkalotic side of things when you have diarrhea, interestingly enough. But this is just a little cartoon for you guys to reflect back on if this is a way that helps it stay in your mind. Talks about the ways, what happens when a patient has too low serum potassium and what to do about it. The clinical manifestations, you will see some depressed neuromuscular reflexivity just because of the action potential of the neuromuscular function. The primary problem, though, is going to be cardiac. ECG changes with premature ventricular contractions. You may lead even to heart block because remember, we're not reorienting that potassium properly to get ready for the action potentials. And I just wanted to include a word about digoxin. If a patient is hypokalemic, they're at greater risk for dig toxicity because dig toxicity interrupts the action of the sodium-potassium ATPase pump. So it's just a little factoid to tuck away. If you find a patient who's a heart patient has a low serum potassium and they're on dig, you might want to get a dig level. And what are the signs of dig toxicity? Do you remember that? Kind of famous and real important because it's such a narrow therapeutic index. Dig toxicity is primarily manifested with GI upset, which is who doesn't have GI upset, right? But if you put it together with visual disturbances of like a colored halo, like I'm seeing a halo around you and it's pink, that kind of thing, that's dig toxicity. So if you see somebody who's hypokalemic and they're on dig and they're talking to you about these changes in their vision, get a dig level. That's real important. Just something to put together. Okay. The management, of course, is to address the underlying cause. It could be something as simple as, oh, this patient is on Lasix and they don't have a potassium supplement. So let's start giving them a little potassium chloride orally. That will right it. That's easy enough. You can do an IV replacement, but you'd never do a direct IV push. It's always in a bag of fluid. Like we'd add sodium chloride or potassium chloride to a liter, but we would never do a direct IV push unless we were in prison and somebody was on death row. That's what they use for death row, potassium chloride, by the way. So you never give a direct IV push of potassium. Oh, and here it is. Very, very important. Anytime you give potassium, you kind of want to know what's going on with the potassium level because there's such a narrow window. I know when I work with nursing students, if a patient's taking Lasix and they're taking a potassium supplement, I always ask them to get a recent potassium level before you give the potassium supplement, just in case. And if they're not taking Lasix, even more so. We need to know what the potassium is because I don't want to bump it too high. Potassium, when you see potassium out of whack, that's important. That's a red flag. And you always think first cardiac. Okay, so that was hypokalemia. On the other side of things would be hyperkalemia. That would be a potassium that's greater than 5.0 milliequivalents per liter in a serum sample. So this is the extracellular, but it's a reflection of the overall potassium. Drugs that increase potassium would be if our same patient, a heart patient, is on now spironolactone, aldactone, which is a potassium-sparing diuretic, they could have a risk for hyperkalemia. Anything that impairs the Rast system is going to lead to an increase in potassium. The Rast system, of course, stands for, what is the Rast system? Does that ring a bell with anybody? The Rast system refers to the Renin-Angiotensin-Aldosterone System. And it is, just real briefly, really important concept. But it's if there's too little blood pressure going into the renal tubule, this is my glomerulus right here, if there's too little blood pressure, then that means what's going to happen? What is the consequence of not enough pressure of the arterioles going into the glomerulus? What's the consequence of that? What's the purpose of the renal tubule? Filter. Very good. That's exactly right. If, however, I've just got a lazy river going by my glomerulus, it's not going to push any filtrate into the renal tubule to be bound for urine. Instead, it's going to stay in the body and build up as a toxin, right? And so because of that, there are these specialized cells that live right in that department, and they're watching the pressure that's coming into the glomerulus of the renal tubule. If it gets too low, they secrete renin. And then renin is going to start a cascade of events that will lead to vasoconstriction, which does what to the blood pressure? Increases it. And it will also lead to aldosterone and ADH to be secreted, which increases the volume in the intravascular space, which does what to the blood pressure? Increases it until it gets back up to snuff and the cells are like, okay, we're good to go. You can stop with the renin. So it's a negative feedback. So when I refer to the Rast system, it has to do with adequate blood pressure to prepare the filtrate to get rid of toxins from our body. Very important system. Anything that interrupts that is going to lead to a hyperkalemia. So if I'm giving a renin inhibitor, or if I'm giving an ACE inhibitor, captopril, lisinopril, any of those, if I'm giving an ARB, a sartan, if you have patients that are taking anything that is going to interfere with that, you could have a risk of hyperkalemia. Okay, alrighty then. Cellular hypoxia, we're going to talk about that in just a moment. Insulin deficiency is going to lead to hyperkalemia because what did I tell you is a relationship between insulin and potassium? What does insulin do to serum potassium? What does insulin do in general? Oh, good. You're absolutely right. It decreases it. That's exactly right. So insulin's primary role is to move the sugar into the cell, but consequently, while it does that, it's also moving the potassium into the cell, which decreases the serum potassium, right? Okie doke. So if we have not enough insulin, there could be a buildup of extracellular potassium. Did that follow? Okie doke. Okay, so those are some of the causes. The clinical manifestations, whether it's hypokalemia or hyperkalemia, I want you to think cardiac. That's the problem. You may have some muscle twitching and some other stuff, but the most life-threatening is cardiac. So if you have anything out of the normal range of potassium, you need to find out what's happening electrically with the heart. Get them on telemetry. Okay. This never stuck with me, but if these mnemonics help you, the way to remember increased serum potassium, you can remember murder, which is not too far off. I mean, because it could be lead to death. Muscle weakness, oliguria, which is decreased urine output, anuria, which is no urine output, respiratory distress, decreased contractility, ECG changes, and hyperreflexia or areflexia. So primarily when you have your potassium out of whack, think of reflexes and cardiac. Primarily cardiac, because that's the one that has to do with life and death. Okay. The management of hyperkalemia, you want to find out what's causing it, first of all, and let's treat that. Makes good sense. And then you want to fix the imbalance. Things such as decreasing the sodium or the potassium intake. You could change whether you're giving a diuretic, you may need to switch from a potassium sparing to a loop diuretic so you can get rid of some of the potassium. If you are in dire need of a pretty quick fix, you can give a calcium gluconate because that's going to help calm down the electrical activity in the heart. Because remember, the calcium is going to prolong that refractory period. So if you have a patient who has hyperkalemia, you may want to prolong that action potential so it's not getting too hypersensitive. So that's one of the reasons. Another thing that you might give is K-exolate. That's a GI kind of thing. You give it orally, and it just helps the body flush out the potassium. We give that quite often in the acute care setting for hyperkalemia. It's a pretty safe way to do it. Very uncomfortable for the patient, but better than cardiac arrest, right? Okay. Easy for me to say. Holy cow, is the nurse. Yeah.
The last one where it says dextrose 50.
Yes. Plus insulin.
That has to be in conjunction with administering insulin.
Yes. That's exactly right. Now, if a patient has a normally functioning pancreas and you give D50, it will secrete insulin and lead to the movement of the sugar into the cell and the potassium. However, usually you have to give insulin along with it so it happens quickly enough that you don't have problems with hyperglycemia. Good question. Any other questions about this slide? All right. Okay, there are just 3 other electrolytes I want to touch on. Is it really that time? Holy cow. Okay, calcium. These are not ones that are real prevalent in the serum. They're primarily, as you guys pointed out, primarily in the bones and in the teeth. It's the most abundant mineral in the body, but the vast majority is located in the bones, in the teeth. When you think of a calcium irregularity, most times you're thinking neuromuscular, so you're thinking reflexes. This is a table that talks about the difference in high and low blood calcium. I wanted to leave it in this so that you could refer to it yourself. I'm not going to take the time to talk through it today. Okay. Phosphate, again, it's an elemental electrolyte. However, it has functioning in things such as DNA, replication, tissue growth, very fundamental issues. So it is important. I don't mean to diminish its importance, but it's not life-threatening, such as potassium or sodium. And magnesium is the last one. Again, it's stored primarily in the bones, as we talked about, has lots of functions as well. But we don't have a real good picture of it from a serum sample because only 1% of it is in the serum. Okay, so let's just think back to, we were talking fluid balance and electrolytes. I just have a couple of questions to make sure you guys are all on track. Whoa, look at you guys. Holy cow, I didn't even give you a chance to read it. Bingo, you're absolutely right. And what are the 3 compartments that they live in? Intravascular, interstitial, all of which are the extracellular, and intracellular, and then the extracellular 2 are intravascular and interstitial, right? You with me? Alrighty, good, good. Okay, here's kind of a thought provoker. What direction will the fluid in each of the following moving into the capillary, C, or into the tissue? And what I want you to think about are the 2 principles that mandate the direction of fluid flow. What were those 2 forces at work? Hydrostatic and osmotic. Good. When you think hydrostatic, what do you think? Push. And when you think osmotic, you think good, good. So with that in mind, let's pretend we have a patient that has an elevated serum sodium. I want you to think, don't say it out loud, but think about, will the fluid move into the capillaries or into the tissues? Maybe make a note, commit to yourself. Patient B has elevated blood pressure. Holy cow, 199 over 102. Will it move the fluid into the capillaries or into the tissues? Make a note. If you have a patient that has edematous, dependent edema in their legs, and you put on TED hose, which applies pressure, think about, is it going to push the fluid into the capillaries or into the tissues? And last, administration of IV fluids, excess administration of IV fluids, so increase in the intravascular. Think about, is it pushing it into the tissues or into the cells? Do you have kind of some answers in your mind? Okay, we'll do the reveal here. If a patient has elevated serum sodium because of the osmotic pull, it will pull the fluid into the vascular space. If they have an elevated blood pressure, because of the increased hydrostatic pressure, it'll push the fluid into the tissues. Yep. If you're applying TED hose, that's actually going to move the fluid into the capillaries. That's the design, by hydrostatic pressure extravascularly. And then excess administration of the fluids, I'm not talking about tonicity, but if we have an increased volume in the intravascular space, it will increase the hydrostatic pressure, pushing the fluid into the tissues. Is everybody clear on those? Hot dog. Alrighty then. Let us now turn our attention to acid-base balance. This is a pretty important concept, and you guys will run into it a lot in pre-hospital care. As you know, body acids are the end products of metabolism. So normal, just us sitting here, we are increasing the acid production in our body just because of cellular metabolism. That's just normal. The primary systems that regulate acid-base balance are the lungs and the kidneys, as you remember. Acid-base balance is absolutely critical for our well-being. In fact, the pH of a normal arterial pH is 7.35 to 7.45. You notice that's a pretty narrow scale, right? And when I say pH, what does that refer to? What does pH mean anyway? Okay, H is the hydrogen, which is an acid. That's a true statement. The P is actually an inverse proportion. So if I have a low pH, what does that mean about the acidity? High acidity, right. So this is an inverse proportion to the hydrogen ion. So if I have a low pH, I have more hydrogen ions, which means I'm in an acidic state. If I have a high pH, I have low hydrogen concentration, or an alkalinic or basic. You with me? All right. And then we mentioned that the primary systems that regulate this are the respiratory system, and the way that that happens is through the movement of CO2, carbon dioxide, because where hydrogen is an acid, I want you to think clinically CO2 is an acid, essentially. So if you have a buildup of CO2, you will be acidotic. If you blow off too much CO2, you'll be alkalotic. And then the other system that gets into the game would be the kidneys, or the renal system, primarily by their either reabsorption or secretion of hydrogen and bicarb. Bicarb, of course, is basic, right, or an alkaline. Okay. This is pretty much what I was just talking about. The greater the concentration of hydrogen ions, the more acidic. And remember, normal cellular metabolism is going to produce hydrogen ions. That's the waste product of normal cellular metabolism. So our body is always working to right or balance the excess acid. That's just normal physiology. Okay. This is the equation I'm sure you all are very familiar with that just shows how carbon dioxide in water becomes, I've just lost it, carbonic acid, sorry, and then it dissociates into hydrogen and bicarb. You'll notice that the arrows are moving back and forth. So if I have an increase in CO2, it can move this direction, or if I need to get rid of CO2, it can move the other direction. Kind of keep in mind this equation so that you can remember that CO2 is equivalent to an acid, bicarb is equivalent to a base. Okay. Oh, sorry. I talked about how normal cellular metabolism leads to an increase in hydrogen ion concentration. Therefore, it leads to what direction of your pH? Decrease. Yeah, more acidic. So just by us sitting here, our pH has been falling. just because we've been producing hydrogen ions. However, we've had things happening in our body that are helping keep it in balance without us even knowing it. Pretty remarkable. The three systems that are at work are the buffer system, which is essentially at the cellular level, the respiratory system, and the renal system. Let us talk first about the first line, or the first line of balance in the acid base. This happens in seconds. We have absolutely no idea it's happening, and it's happening even as we sit here. So as there is a buildup of hydrogen ions, those hydrogen ions are going to be buffered at the cellular level by a number of different ways. Number one, they will get together with bicarbs that are floating in my serum, cause carbonic acid, go to my lungs to be breathed out as carbon dioxide because of that equation. That's one way. Number two, and this is kind of cool, if there's too much hydrogen extracellularly, remember that's a positively charged ion, there can simply be an exchange with potassium. So if I have too much hydrogen extracellularly, one of my intracellular potassium can trade places to decrease the hydrogen concentration in the serum, but it consequently will do what to the concentration of potassium in the serum? It'll increase it, right? Because I'm exchanging. So if I have a buildup of hydrogen ion because of normal metabolism, and I want to decrease that, one way to decrease it is to exchange it for potassium, take it inside the cell. So it's no longer in play. But consequently, it's going to raise the potassium. So it can do that to a point. And then the other way is that there are body proteins such as hemoglobin in our red blood cells that when we have excess hydrogen ions, they will connect with the hemoglobin to take it out of play. That also buffers the hydrogen ion. These things are happening right now, even as we're thinking. That can only help us to a point though, because you know it's reorienting or redistributing the hydrogen ion. It's not getting rid of the acid, right? It's just taking it out of play. So when that first line is no longer adequate, that's when the second line gets involved, and that would be the respiratory buffer system. The way that if I have a buildup of acid in my body and my cellular buffer systems are not adequate to keep my pH in balance, then my respiratory system is going to get involved. And remember we said that CO2 is what? A base or an acid? It's an acid. Therefore, I can breathe off the CO2. It will increase my respiratory rate, will help to right my pH. Isn't that so cool? And this will happen in minutes to hours. So if I'm taking care of a patient who has an acid-base imbalance, let's say they have a metabolic acidosis, I may see my patient increasing their respiratory rate, and during my shift, I'll probably see that pH come back within normal range because it happens that quickly, as long as the patient's able to keep up with getting rid of the CO2. It's a pretty efficient system to a point. If, however, so hyperventilation, increasing the respiratory rate, breathes off the CO2, which will lower the hydrogen concentration or increase the pH, right? If, however, hypoventilation means I retain the CO2, that's going to increase the hydrogen concentration and decrease my pH. Okay? The other system that gets involved, and this actually takes hours to days to get involved, is when the kidneys recognize that there is an imbalance. If there is an acidosis, say I have respiratory acidosis because I've had a head injury and I'm not breathing adequately, my kidneys will recognize that, holy cow, this pH is way too low. I need to get rid of some hydrogen. So it will start hanging on to the bicarb and getting rid of the hydrogen. That's how the kidneys get into the game, by either hanging on to or letting go of bicarb and hydrogen. But it takes longer for that to happen. Okay. So when the hydrogen levels are high, the kidneys will do which of these? Commit, and then I'll reveal. I heard reabsorb. Gosh, what is crazy with that? Reabsorb the bicarb, because remember I have too much hydrogen ion. That means I'm going to have an acidotic state. So I need to actually hang on to the bicarb to buffer it, right? So if I were to excrete the bicarb, it's going to make the problem even worse, right? Because those two are inversely proportional. Okie doke. If I, by the way, have too much hydrogen ion, is my pH going to be too high or too low? If I have too much, yeah, too low. If I have too much hydrogen ion, I have a low pH. How confusing can we make this in one fell swoop? Holy cow. Okay. So the next, boom, you guys are good. Hyperventilation causes, so you've got a patient that you've responded to and they are anxious and they're hyperventilating. So you know that they are bound for what problem? Bingo. Oh, hello. Good Lord, oh Pete. Yeah. Getting rid of the hydrogen, right. So if they're getting rid of the hydrogen, that means what's happening to their pH? It's going up. So in this case, this would actually be a respiratory alkalosis because they're getting rid of the hydrogen ion, right? Because they're getting rid of the CO2. Okay. Yeah, oh.
William Shatner get a hold of your slides?
Apparently. No, it's tribbles. Clearly, it must be tribbles. What in the world? Holy cow. Okay. So when you interpret ABGs, the way that you approach that is, first of all, you look at the pH. That's the very first part of the ABGs, arterial blood gases that you're looking at. And you want to see if it's within normal range. And if it is, all is well. If it isn't, though, then you know it's either acidotic, which means the pH is too low, or it's alkalotic, which means the pH is too high or basic. The next thing you look at is the PaCO2, which is another number you get with the ABGs. If you have too high of a PaCO2, remember CO2 is what, an acid or a base? Acid. So if you have too much CO2, you're going to be acidotic, right on. So if you have an acidotic pH, let's say a 7.32, and you have a PaCO2 of 52, you can pretty much nail this is a respiratory acidosis because those are both acidotic, okay? And then when you look at the bicarb, which is reflective of the kidney function or the renal function, I remember that if I have too much bicarb, it's going to be alkaline. If I have too little bicarb, it'll be acidotic. This can really be helpful when you come upon a patient who is in an acid-base imbalance. You're going to take into effect what is the clinical picture. Did this person have a head injury and therefore is not getting rid of the CO2? Then that means they're respiratory acidosis. Then you're going to be able to look at the bicarb and say, has this been going on long enough for the kidneys to get involved or not? Depending on whether or not the kidneys are, the ABGs are within normal limits. Sadly, we don't have time today to play with this. But if you're at all interested, I've got lots of exercises for you to play with to check your understanding of how to interpret ABGs and how it helps sometimes to make sense of what's happening physiologically to lead to this imbalance and whether or not the other system is involved. So just let me know.
Are those things that you could email to somebody?
I could happily do that.
So Scott will be sending out Janelle's email at Gonzaga. If you want one of those, just email her and she'll shoot it to you.
You bet your boots. I'll give you my handout and I'll give you the key just for kicks. Call me crazy. Call me wacky. Okay. So remember that if there's a metabolic imbalance, it has to do with kidney function because they regulate the bicarb and the hydrogen. If there's a respiratory issue, it's going to be a respiratory imbalance because the respiratory issue is going to regulate the CO2, which is essentially an acid. Okay. I'm going to leave these on here because these are great examples of when you would get into this, but in order for us to have time to talk even briefly about shock, I probably better sail through these. Is that okay, or should we finish this? What's your pleasure?
If you go till 12:15 or 12:20, are you guys okay with that?
What, you have no lunch dates? What's up with that? What? Okay.
You can do a half an hour more.
Okay, I'll give it a go here. If you need to leave,
you guys will get triple time paid.
if you need to leave, please feel free. Okay, So respiratory acidosis. Acidosis means that your pH is too low, but with respiratory, that means your PaCO2 is too high because CO2 is an acid. Some of the causes would be any kind of a lung disease that is going to impair the ability to get rid of CO2, such as COPD, a chest injury, an airway obstruction. Severe obesity can lead to respiratory acidosis because they don't have the energy to get rid of the CO2. This is, again, just another cartoon to help you remember the causes of it and the manifestations. Respiratory alkalosis is the other side. That's if you're getting rid of too much CO2. Almost all of the times I've seen respiratory alkalosis is when a patient's been anxious. That's 99% of the times I've seen it anyway. It can also be caused by other disorders as well. And this is, incidentally, if you have a patient, you've probably seen on TV shows, if you have a patient who's hyperventilating, they'll give them a paper bag. How is that going to help them? Recycle the CO2. You betcha. So it's going to keep them from blowing off too much CO2 and instead put it back in their system. That's exactly right. Good. Okay, metabolic acidosis. This is usually to do with kidney stuff, not respiratory, but kidney stuff. This is when there is a pH that's too low and a bicarb that is too low, because bicarb is the opposite, is the buffer for an acid, right? If you have a patient with chronic renal failure and their acid-base imbalance, you can bet your bottom dollar they're going to have metabolic acidosis. Bet your bottom dollar. Sometimes we see this with severe diarrhea. Sometimes we see it in situations of shock because they're not able to get rid of acidosis. And DKA is another classic example of a metabolic acidosis. Here's another cartoon to just kind of help you remember the causes and the manifestations of metabolic acidosis. Metabolic alkalosis, remember, is when the pH is too high, and in this case, the bicarb is too high. And that could be either gastric suctioning or vomiting for several days, or sometimes we see that with patients that have just gone overboard. We used to see it more in the ER than we do now, with patients who, older patients who are trouble with their bowels, and they'll just drink sodium bicarb as a laxative. We used to see it a lot more. Thankfully, there are other laxatives to be used out there, but that would lead to a metabolic alkalosis. Okay, whoops, sorry. That was just another cartoon that displays what causes metabolic alkalosis and how it would be clinically manifested. Okay, here's a little brain teaser for you. I want you to take a moment and look at the things on this side, increased bicarbonate, and would that be reflected as respiratory acidosis, respiratory alkalosis, et cetera, et cetera. So match the numbers with the letters. I'm going to give you a few moments to do that, and please commit, because that's the best way to know whether you understand this or not. Do 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 boom do 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 do. Okay. Okay, I'm going to do the reveal. I just have to say thank you for diving into this with both sides of your brain. Bravo. I could see the brain cells working. Thank you for doing that. It hurt? It hurt. I could see it working. Okay, so increased bicarb would best match with metabolic alkalosis. Do you agree with that? Decreased CO2, anytime you see CO2, it's going to be respiratory. I'll give you a hint. Decreased CO2 is going to be respiratory alkalosis, because remember CO2 is an acid. God bless you. Increased CO2, the opposite. So if somebody has a pillow over my head, or I have a head injury where I can't breathe enough, and I have increased CO2, it will be respiratory acidosis. And decreased bicarb would match with metabolic acidosis. Answer 3. Any questions about those? All right. Here's one last brain teaser for you. I want you to think about each of these situations and think what would be the potential acid-base imbalance if this is the clinical presentation. Feel free to use your comrades next to you on your table. See what you come up with. I'm going to go ahead and do the reveal. You guys, I have to applaud you for a couple of things. Number one, you're mulling this over. I remember I had an amazing mentor who said to me, you know, one of the things that healthcare providers don't do enough of is we don't give ourselves permissions to mull it over, just to let things simmer, to really understand it, because we're so action-oriented and we want to cross off the to-do list. We don't give ourselves time to really reflect and think about it. That's what you're doing right now. Bravo. Number two, the thing I'm seeing here is that you're using each other. You are your best resources in the field to use one another to bounce ideas off of. I hope that you will embrace that and continue to do that. I know when I'm working, I am always saying, hey, could you listen to this with me? Or, hey, I'm looking at this lab value. Here's what I'm thinking. What do you think? I'm always bouncing ideas off people I'm working with. It helps me be a better provider. So bravo to you for doing that. Let's look at the reveal here. Severe diarrhea would most likely be reflected as metabolic acidosis because you're losing the alkaline, right? Panic attack, we talked about breathing off too much CO2, so that would be respiratory alkalosis. COPD is going to impair the ability to get rid of the CO2, so it'd be respiratory acidosis. Ingestion of Tums, which is a laxative, metabolic alkalosis. Any questions about those? All right. Bravo. Okay. Oh, I thought I was done with this one. Which patient would be greatest risk for fluid volume excess? Oh, we're pulling this one through from last discussion. Read those options and tell me which one you think. Fluid volume excess. Best answer would be, indeed, kidney failure, because you're not able to get rid of the fluid. Very good. Very good. Okay, the very last category that I wanted to just touch on briefly is hypoperfusion or shock. Remember we talked about way back 12 years ago when we started talking today, we talked about one of the cellular injury is caused by hypoxia, right? One of the reasons there is hypoxia is when there's not enough perfusion at the cellular level. And if there is enough hypoperfusion, it will lead to shock, which is a life-threatening situation. We're going to talk about different types of shock. Tissue perfusion, first of all, is the circulation of blood through the vascular bed of tissue. So I think you can appreciate that if I tied something around my wrist and my hand started getting white and I'd lose, that would decrease the perfusion to this extremity, yes? So anything that decreases the ability of the blood to deliver oxygen and fluids is perfusion. Hypoperfusion occurs when the level of tissue perfusion decreases. And if hypoperfusion is allowed to progress without intervention, it will lead to shock. Shock is a life-threatening disturbance of circulatory failure. It is the inability to maintain adequate tissue perfusion, which leads to cellular hypoxia and cellular destruction. Whenever I'm thinking of shock, I'm always thinking of three components. One of these three components is impaired. And it's important that we identify which component so we know how to right the problem and how to address it, how to make it better. It's either the blood volume, the heart function, or the vascular tone. Okay. Your book actually divides these into either central or peripheral. When it's talking central, when your authors are talking about central shock, it's all referring to the pump. So either cardiogenic shock, such as a myocardial infarction where the pump's no longer pumping, that would lead to shock. It could be heart failure that has progressed to the degree that it's no longer consistent with health. In addition, you could have an obstructive shock. I have a couple of pictures of this. Anything that keeps the pump from pumping right, such as a cardiac tamponade, which is fluid in the pericardial space that doesn't allow it to pump, or if you have pneumothorax and it's pushing everything over so there's too much pressure on the heart to pump, anything that impairs the pump is considered central shock. Peripheral includes hypovolemic, like you see in trauma or profound diarrhea or vomiting, or distributive shock, which is, I always think of distributive shock as the problem is at the site of distribution to the cells. So anaphylactic is when the histamines have impaired the ability of the oxygen to get to the cells. Neurogenic is anytime there's a discommunication between the sympathetic nervous system and the body. And then septic shock, which you guys will see a lot, that's when there is such an massive inflammation and massive response to the infection that there is vasodilation to the point where it has impaired the ability of oxygen to be delivered to the cells. Septic shock. All of them land with an ineffective delivery of oxygen and nutrients to the cells. That's the problem with shock. Here's an example of, this is why it's considered central. Cardiac tamponade, of course, is where there's supposed to be just a little bit of fluid in the pericardial sac to decrease the friction when the heart pumps. But if something happens and there's an increased fluid volume, it's going to impair the ability of the heart to pump. Central shock, obstructive shock. Same with tension pneumothorax, obstructive because the pressure is impairing the ability of the heart to pump. Okay, in general, the manifestations of shock are as follows. The skin is almost always cool and clammy because remember we have a decreased perfusion to the extremities. Decreased capillary refill, which means when I squeeze that blood out of that little capillary, it doesn't get replaced. And so I have a prolonged capillary refill. Pale, mottled, even cyanotic. The exception to this would be septic shock. Because if I have bacteria that are causing an infection, that's going to actually raise my body temperature. So that's the exception to this general manifestation. With regard to renal, there's a decreased urine output because remember, there's not enough pressure getting to the tubules to produce urine, right? Decreased urine output. Increased specific gravity, increased BUN and creatinine because nothing's getting filtered into Mr. Tubule. Renal failure. Metabolically, there's going to be hypercapnia. What is hypercapnia? Increase in CO2, hypercapnia. Fancy word for increased CO2 because that's a byproduct of metabolism. Increased lactic acid. Why is there an increased lactic acid? We're diving down back into the cellular biology that you guys learned. Yes, that's exactly. It's building up in the cells because what is not available for normal energy production? Oxygen. If there's not an oxygen available for normal cellular function, it's going to switch from aerobic metabolism to anaerobic metabolism. The waste product for anaerobic metabolism is lactic acid. And lactic acid, very dangerous. Our body does not like lactic acid. Sends us into a metabolic acidosis, of course. And by the way, anaerobic metabolism, nowhere near as efficient as aerobic. And so very slowly, our body starts shutting down because it doesn't have the energy to continue with the sodium potassium pump or any of the metabolic functions at the cellular level. Very, very important. So lactic acid is a key lab value that we look for when we have a patient who's in shock. GI, we'll see a paralytic ileus because remember, we don't have innervation of that organ. Decreased bowel sounds. There's going to be shunting of the tissue of the perfusion. I hate to tell you this, but the GI system is not considered a vital organ. Yep, believe it or not. And so it's going to shunt it away from there to the brain and to the kidneys and to the heart. Neurologic, there's anxiety. Decreased level of consciousness can progress to a coma. Honestly, some of the first times I recognize a patient's going into shock is because somebody who was pretty normal and doing okay, suddenly they're very anxious. That's a cardinal sign. Something's going on. I need to assess a little bit more closely. Cardiopulmonary, almost always we'll see an increase in heart rate. Why would we see an increase in heart rate? You betcha. Our body's trying to compensate. This is a alarm situation. Sympathetic nervous system is innervating, increasing the heart rate to circulate whatever oxygen is available. The exception to that is neurogenic shock. Because neurogenic shock, we've lost the sympathetic connection. So our brain may recognize, warning, Will Robinson, we're in trouble, but we can't send any message back to increase the heart rate or to write it. Okay? So that's the exception. Weak, thready pulses. Initially, there will be an increase in blood pressure, but honestly, by the time we get there, that's going to wear out because we're going to run out of the energy, and there will be a decrease in blood pressure. Cardinal sign of shock is decreased blood pressure. Increased respiratory rate. Depending upon what's happening with the heart muscle and the energy available to it, maybe an increase or a decrease in the contractility. And same with the systemic vascular resistance, depending on if we're in the compensatory or the decompensation stage of shock. Almost always when we get involved, we're in the decompensation stage of shock. By that, what I mean is when our body recognizes, holy cow, I'm in trouble, the sympathetic nervous system will kick in and it will cause vasoconstriction and increased heart rate and all this great stuff. But very soon, I'm going to run out of energy to keep that tone and to keep the heart rate. And so things are going to start slowing down, and that's when we usually get involved. Okay? Any questions about these general manifestations? Okay. In general, the goal of shock, of course, is to improve and preserve the function of tissue. That's our ultimate goal. Identify the type and the cause of the shock and correct it. Support oxygenation and tissue perfusion. If it is hypovolemic, which is a peripheral shock, we want to replace the volume. We want to increase the cardiac output without increasing the workload, because remember, there's not a lot of energy available. So we may give something that's a positive inotrope, but nothing that increases the heart rate too much. Vasopressors are going to simply increase the tone of the vasculature, but don't do that until you've replaced the fluid volume, or you'll be making the problem worse if it's hypovolemic. So you kind of need to identify what type it is before you attack it. If it is septic shock, really important to know, the first thing you do is get cultures. And then you start, research has said that if you can start the patient on broad spectrum antibiotics within the first hour, their chances of survival are astronomically better. Now, once the blood cultures come back in 48 hours, we may need to switch the type of antibiotic. But if we wait until the blood cultures come back to start treating them with antibiotics, they'll be dead. So we need to get blood cultures and then start them on antibiotics within the first hour if it's septic shock. Okay. If all of our efforts do not right the situation, the danger for our patient is what is called multiple organ dysfunction syndrome. And there's only so long that a body can be sustained without perfusion to the cells of oxygen and nutrients. and it will progress to MODS, which is an irreversible next step death, essentially. Now, how quickly a patient progresses to that will depend upon a number of factors. What are some factors do you suppose would impact that? Size of the patient, you bet. What else? Age of the patient, you betcha. Some young high schooler that's in some sort of a shock will have a whole lot better chance than me if I go into shock, because they've got age on their side. And just their physical health. If somebody is pretty healthy to start with, they've got a longer time to work with than a 92-year-old multi-system disorder patient. They don't have as much time. So we factor all of this in as we're taking care of our patients. Think about their prognosis.
Would you say environment to play into that? So like if they're out in the cold or...
Talk to me about that. What are you thinking?
Well, just like, I mean, I guess if they're in a cold environment and you're going through some, just say like an accident or something, you know, their body's going to have a harder time overcoming that, I would suspect.
Okay, you've brought up a really important point. The comment was that if a patient's in a cold environment, what impact will that have on their progression? What does a decreased temperature do to the metabolic demands? It slows it down. So remarkably, a cold environment actually gives a patient longer in a shock situation. So much so that there has been research investigating, can we bring the body temperature down until we can get them into an acute care setting? So really, really good perception in that question. If we can manipulate the environment to the degree that we can decrease the demand in the body, we can preserve their life. Very good. Now, consequently, the other is true. If they're in exposure and they have hypovolemia and they're in the desert and they have no access, that's going to be more devastating. And it's not going to work in their advantage, obviously. But if we can slow down the metabolism, that's a good thing. Any other questions? Comments? Right, I think I've got, this is just, I'm going to include this on your PowerPoint so you have access to it. It helps me if I am comparing different types of shock, if I can pull out what is the abnormal, what's the outlier. For example, neurogenic, I'll have a decreased heart rate. All other shocks, I have an increased heart rate. With septic shock, what's different with septic shock than with all other shocks? Yes, all other shocks are cool and clammy. Septic shock will be warm. Very good. So I try to look for the outliers, and then I can remember the general. Okay, when oxygen does not reach the cell reverts to, you guys didn't even blink, holy cow, anaerobic. And what is the waste product from anaerobic? Lactic acid, which increases in the situation of shock. Okay, what would be the most likely cause of a respiratory acidosis? Ooh. I think this is the last question. The best answer, what would be the most likely cause of respiratory acidosis? Nearly drowning, because they're not getting rid of the CO2, right? Okay, oh, sorry, one more. In septic shock, bacterial endotoxins cause vascular changes that result in decreased systemic vascular resistance. So in other words, vasodilation and decreased blood pressure. Is that true or false? True. Any good presenter ends on a true statement. Yes. All right. Any questions before we call it a day? Thank you guys for your attention. It's been a joy to be here. Good grace with your test. Please let me know if you have questions along the way. I'll be happy to talk with you over email. Let's ask Steve to make sure. Steve, did you say who sent out my email address? Scott Dietrich. There you go. You betcha. It's nice to meet you, Max. Good to meet you. I think I got your name. I'm Janet.
Chad.